everyone, and it's great pleasure to invite for today's webinar, Advancing in Cancer Care, Clinical Updates in Lung and Breast Cancer. So yesterday we discussed about lung cancer. So today we discussed about the breast cancer, and I would like to invite Dr. Pranshu Chaudhary, sir. He's a consultant medical oncology, IV Hospital Mohali. So it's over to you, sir.
Thank you, Gitika. And we discussed about lung cancer yesterday, and today we'll be discussing mainly breast cancer with one topic each of head and neck and ovarian cancer. So, for the first talk today, which is sponsored by Merck, I'll be inviting Dr. Neha Gupta, who is a medical oncologist at Max Hospital, Bathinda. She'll be speaking on management of oral cavity cancers in metastatic setting of head and neck. So, over to you, Dr. Neha, and welcome.
Good evening, sir. Thank you, organizers and Dr. Priyanshu, for making me a part of this virtual CME. So today I'll be talking about oral cavity cancers. Is my screen visible to everyone?
No, ma'am.
Hello?
Yes, it's visible now.
Okay, today we'll be talking about the first-line treatment in recurrent and metastatic setting in oral cavities, squamous cell carcinoma. As we all know how the treatment landscape is evolving from previous to now. Earlier, we used to have chemotherapy, single agent, then came into action the double agent chemotherapy, and then came extreme regimen in which we have given cis-5FU. We can see the improvement in outcome when cetuximab was added to the chemotherapy around 10 months. And then from cetuximab, the immunotherapy era came into action in 2016, in which pembro was added to cis-5FU, and it was given refractory settings after cisplatin refractory settings. And then come the TPX trial, in which they have combined cetuximab with docetaxel and cisplatin. And also we have seen immunochemotherapy combining with cis-5FU. So we can see that how the OS advantage is being increasing from 6 months to 14 months when we have these two drugs like cetuximab and pembrolizumab. And then came the trial in which we have seen that when we have added cetuxi, paclitaxel followed by nivolumab on progression, we can see our OS advantage increasing to 22 months. We can, as we all know, that the most common cancers in the oral cavity are buccal mucosa and the tongue, which is the most affected area in the oral cavity cancers. These are the NCCN guidelines, latest NCCN guidelines highlighting the first-line therapy in squamous cell carcinoma, head and neck. As we can see that we have recommendations. In the first line, we can use pembro cis-5FU, or we can use cetuximab cis-5FU. So today we'll be discussing what to use first and how to use and how to sequence our treatment. As we all know that we cannot only start treatment based on these guidelines. We have to see so many factors depending on patient and disease related factors before deciding what chemotherapy or what immunotherapy or what targeted agent to use first, followed by the second one. As we all know that Indian patients are being different, so these NCCN guidelines are based on the Western data. So we also should check on our patient which therapy will be working better as compared to the other therapy. As we all know that in Indian patient, the most common oral cavity cancers are there because of increased amount of smoking, tobacco, and alcohol. And HPV prevalence is less in Indian population as compared to the Western population. And Indian patient present usually at the advanced stage and with aggressive biology. So before choosing the treatment, we have to first decide and discuss what all treatment options do we have. Then come we have already discussed that we have the most common advanced stage cancers which are being seen in oral cavity cancer because of ignorance and because of lack of awareness. Patients usually presenting at advanced stage, which are highly disease burdened and are very symptomatic. So before deciding the treatment, we should first know all of these factors clinical as well as patient-related factors. What the disease burden in the patient, what is the rapidity of the response we need in the patient, and what all biomarkers we need, like CPS scoring. We used to get in patient in first line setting to decide whether to give immunotherapy or to decide whether to give cetuximab in the first line settings. And then also we need to know about the comorbidities of the patient, about the performance score before deciding the treatment. As we all know, when the patient come in the with the high very disease burden and in very symptomatic condition, patient expectation is only to relieve the symptoms first, followed by anything else. So our basic goal is rapidity of response, and we want to decrease the symptom as early as possible, so that patient can have normal quality of life. In this, we'll be discussing about the two clinical trials. One is in targeted therapy. The other one is immunotherapy in the first line settings. So first, we'll be discussing about the cetuximab plus chemotherapy trials. As we all know, that first trial which came into action was Extreme trial in 2008, in which cetuximab was added with CYST5FU, in which we can see the response rate of 36% with median OS of 10.1 months. And the same was proved in 2019 in Change 2 study also, in which the same response rate increased to 50% and the same median OS of 10.1 months. Then came the extreme arm of TP extreme, that is, in which we have added cetuximab with taxane plus cisplatin or carboplatin, in which we have seen increase of median OS of 13.4 months. So with this, we want to show that by adding CYST5FU or by adding paclitaxel with cetuximab, our median OS advantage of 13.4 to 40.7 months is there. Then come the Indian real world studies, which demonstrating the OS benefit in oral cavity tumors when we treat with cetuximab plus chemotherapy. As we can see that the most common, the site was taken oral cavity. The maximum number of patients and the good responses were seen when cetuximab was added with chemotherapy in oral cavity cancers. We can see an extreme phase 3 trial also, which is favoring cetuximab plus chemo in oral cavity cancers with median OS of 11 months versus 4.4 months. And then we can see in Change 2 phase 3 trial also, in which we have seen that the number of patients were 46 as compared to the other site patients. In this also, cetuximab plus chemotherapy was in favor when we have given in oral cavity cancers. Then this is the Indian study which was conducted. In this, cetuximab was combined with taxane plus carboplatin. In this, the maximum number of patients were oral cavity cancers, like 64% of patients, with overall response rate of 77.1% when cetuximab was added with chemotherapy. We can see in this Kaplan-Meier curve, which is beautifully being separated when cetuximab plus chemo was added as compared to chemo alone, and overall survival as an PFS advantage. So we can see that OS and PFS advantage was there when cetuximab was given along with chemotherapy. The same study was presented in ICC Congress. In this, they have presented in all these three sites in oral cavity, oropharynx, and the laryngeal carcinomas, in which we can clearly see that when cetuximab plus chemo was given in oral cavity cancers, the median OS was doubled. Like when chemo alone, 5.8 months versus 12.23 months in cetuximab plus chemo arm. So doubling of OS was seen in oral cavity cancer when cetuximab plus chemotherapy was given. This is the next data in which we have seen that when we give cetuximab plus paclitaxel and then we give followed by nivolumab in the second line in platinum sensitive recurrent setting, there are wonderful results being seen in this particular study with overall response rate of 32%, 59.3%, and PFS of 7 months with median OS of 15 months. We can see in these two graphs that median PFS and OS advantage was there when we added nivolumab in the second line as compared to in the first line. Then comes the role of immunotherapy as a first-line setting in recurrent and metastatic head and neck cancers. In this KEYNOTE-048 study, we have seen there are 3 arms in which they have taken Pambro monotherapy versus Pambro plus chemotherapy versus Cetuxi plus chemotherapy. Followed by Pambro maintenance and followed by Cetuxi maintenance. In this KEYNOTE-048 study, we have seen when the CPS score was more than 20, overall response rate were more than Pembro plus cis-5FU arm as compared to Cetuxi cis-5FU arm. But at the same time, the progressive disease rate was more in Pembro cis-5FU arm when CPS score was more than equal to 20, that is 15 as compared to 8%. So we don't know the right cutoff, whether we should add Pambro along with chemo and CPS more than equal to 20, or we should wait till CPS more than equal to 50. Now, before deciding about whether to add immuno versus Cetuxi, we should look for the following factors. Like we know that if the neutrophil to lymphocyte ratio is more than 5 and sum of target lesion is more than 4, in the high disease burden, the Pambro cis-5FU, Pambro plus chemotherapy don't work that good, and the progressive disease is seen more in all these patients. So these are 2 factors which we have to see before deciding about what therapy to choose first. These are the graph which is showing that if the CPS is more than equal to 1 or 1 to 19, there was no PFS benefit which was seen with Pambro plus chemotherapy as compared to Cetuxi plus chemotherapy arm. This is clearly showing that this is the main thing which we have to see, that if CPS is more than 1 and if the disease burden is only in the local setting, local recurrent setting is there, then we have seen all these diamonds. In the last, we can see in the recurrent setting, the diamond is favoring more towards Cetuxi plus chemo as compared to Pambro now. Similarly, we can see when we've seen Pambro chemo versus Cetuxi chemo. In this slide also, we can see if the patient is having metastatic settings, then Pambro works well as compared to Cetuxi. And when the patient is having local only disease, then the Cetuxi plus chemo. Hello?
Yes, ma'am.
In this, we can see that if the
Ma'am,
immunocheckpoint
ma'am,
inhibitors
your
are being
screen is
added,
not visible.
now that visible.
No, ma'am.
Is it visible now?
Not now, ma'am.
Ma'am, can we run from our side?
Ma'am, we don't
Yeah, we
have
can run from here.
her PPT slide.
We have
I've
on
shared
WhatsApp. Yeah, she has shared on WhatsApp group. Just check. It's visible now, ma'am.
Okay. In this slide, we can see that there's less amount of response seen in immuno checkpoint inhibitors as compared to cetuximab, just because we know that oral cavity cancer usually come with a high disease burden in a very high load because of increased amount of tobacco and alcohol. So this is we have to see that why the patient don't respond to immunotherapy in oral cavity subside only because it can be one of the reason that immune evasion mechanism is there in oral cavity as compared to other subsite, which is leading to a resistance of immunotherapy in this particular subsite. But it cannot be confirmed. It has to be yet to be proved. Now, how have in this, we have seen that cetuximab works in a double action. That is, once cetuximab inhibits, blocks the EGFR, which induces tumor cell death. At the same time, cetuximab also increases the PD-L1 expression, which also helps in decreasing the angiogenesis, decrease the proliferation, and decrease the metastasis, and causing the immunogenic cell death. So, co-targeting immunosuppressive processes, firstly cetuxi and then second-line immuno checkpoint inhibitor, can be a wonderful thing which can help us to improve the patient outcome in recurrent and metastatic settings of squamous cell carcinoma head and neck. In this also we can see that there are two trials which have been happening. In this, which we have combined cetuxi plus paclicarbo with median OS of 14.5 months. And when the patient progresses, we can then we switch to nivolumab. Then we can see that in the second line setting, when we have added immunotherapy in this, we can see the median OS reaching up to 21.9 months. So in TP extreme, first line Erbitux plus chemo followed by chemo has shown a wonderful OS advantage of 21.9 months. This is the Indian study which has been conducted in which again cetuxi plus paclicarbo was given in first line, followed by nivolumab in the second line with median OS of 20.4 months. This is the study which has been conducted in the first line cetuxi, followed by second line immuno checkpoint inhibitor. It can be considered in the patient with very large tumor burden and in which we want a rapid response to come to relieve the symptom rapidly so that patient can have a better quality of life. In this also they have done cetuxi plus 5FU in the first line, followed by Pamro or Nivo. In the second line, we can see a wonderful response rate of 73% and with median OS of 23.7 months. As compared when we have given immuno in the first line, followed by cetuxi in the second line, we can see decreased response rate of 37%. This is some of the factors which will help us to decide while choosing our treatment options. When we have a bulky tumor with necrosis with high tumor burden, with rapidity of growth, and we want rapid response, rapid achievement of responses, then we should favor cetuxi plus chemotherapy. And when the disease burden is small, and when we have a distant site, then we should favor pembro over cetuximab. And the last, I want to conclude my discussion that each patient of head and neck cancer in the recurrent setting is unique. So you should decide your treatment based on patient priorities and patient needs and your own personal experiences. So factors like tumor burden, phase of disease, biomarker status are important in deciding treatment in recurrent and metastatic head and neck cancers. With cetuximab, it is easy to choose chemotherapy regimen, and we can also, as we know that there is the latest data coming in, cetuxi followed by nivolumab. So we can go ahead with first line cetuxi, and then on progression we can switch our patient to nivolumab. So thank you so much.
Thank you, Dr. Neha, for giving this wonderful talk. And I think so. This is an important aspect in treating head and neck cancers because these are the cancers which have usually poor prognosis in the recurrent setting, recurrent and metastatic setting. So sequencing is, I think, so very important. And the other point is that the performance status falls very rapidly in these patients, and so the sequencing, as you have mentioned, is very important so that we have to utilize all the available drugs which we have. So I think so your take on uh, say, I mean, the latest one which we have is oral metronomic therapy plus IO. Probably that we can use in the later line than first line cetuximab with chemotherapy. So, what do you think should be the sequence?
So I personally go ahead with Cetuxi plus chemo in the first line, followed by immunotherapy in the second line. Because I've also personally also feel that the response rate of with Cetuxi is better when we combine with chemo as compared to Pambro plus chemo. The rapidity of responses are there. Patient feel decrease in the pain, in the symptoms much rapidly with Cetuxi as compared to immunotherapy.
Yes, yes, and also we don't need any biomarker testing upfront, so we don't have to wait for that also. I think so that also might be one reason to choose. So thank you again, Dr. Neha. And so we move on to our next session, which is sponsored by Sepla. So for the first talk, I'll be inviting Dr. Mukesh Bansal, who is a senior consultant medical oncologist at Alchemist Hospital, Panchkula, and he'll be talking about the role of monoclonal antibodies in the management of ovarian cancer. So over to you, Dr. Mukesh.
Uh, Good evening, everyone. Thank you, Dr. Priyanshu, for giving me the platform. Uh, I'm not able to share the screen. Just a minute. Can someone share the screen? I'm getting some errors. Yeah. So thank you once again, Dr. Priyanshu, for giving me the platform. And at the outset, I will like to say that this is a sponsored session, and the slides are provided to me by Cipla. So I will be discussing on role of monoclonal antibodies in recurrent ovarian cancer. Next slide, please. So if we look uh, at the drugs which are approved and which are effective in ovarian cancer, so starting from the late 1970s, cisplatin was the first one, which established the role of platinums in the ovarian cancer. Then came its congener carboplatin, which was the less toxic option. Then there was widespread use of cytoreductive surgeries happened in 1990s. Then taxanes came and paclitaxel was FDA approved in 1992. After that, the BRCA mutations were discovered and found to be playing an important role, but for about 2 decades, there were no new drugs. And then came the 2011 when bevacizumab started to gain recognition in ovarian cancer, and in 2014 it was approved. Then we have all kinds of PARP inhibitors, and now mirvetuximab soravtansine was also FDA approved for receptor alpha in 2022. So these are the drugs. So two MABs which are approved are bevacizumab and mirvetuximab. We will be talking about them. Next slide, please. So bevacizumab 0218 study, it was stage 3, stage 4 epithelial ovarian fallopian tube or primary peritoneal cancer. Performance status 012 patients were eligible. Debulking was done, and eligible patients had resected FICO stage 3 or stage 4 disease. Randomization was done. 3 arms were there. First arm chemotherapy plus placebo, followed by placebo. Second arm chemotherapy plus bevacizumab, but maintenance bevacizumab was not given. It was placebo only. And in the third arm, chemo plus bev, followed by bev maintenance was there. So 6 cycles of induction and then 7 to 22 cycles of bevacizumab in the maintenance arm was given, or till progression. Bevacizumab dose used was 15 mg per kg 3 weekly. Pacli standard dose of 175 mg per square meter, and carbo AUC6. Next slide, please. So if we talk about the median progression-free survival, it was 6.2 months benefit, 12 months in the chemo plus placebo arm compared to 18.2 months in the chemo plus bev arm. So it established the role of bevacizumab in ovarian cancer. But the point to note here is that bevacizumab, when it was continued in the maintenance also, then only mainly the benefit appeared. If it was used in the induction only and in maintenance it was switched to placebo, then significant progression-free survival benefit was not there. So it's important, if we are using bevacizumab, it should be continued in the maintenance also. Next slide, please. So the OCEAN study, platinum-sensitive ovarian cancer who have not received prior chemo in the recurrent setting or prior BEV treatment, platinum-sensitive patients were taken. No prior chemo was allowed. in the recurrent setting. It can be given in the adjuvant or neoadjuvant setting. Performance status 0 and 1 patients were only allowed. Bev was again used in the 15 mg per kg 3 weekly dose for 6 and up to 10 cycles. So in one arm, it was chemo plus Bev followed by Bev maintenance, and in the other, it was chemo plus placebo followed by placebo maintenance. So Bev was not used in the other arm. So main efficacy outcome measures were progression-free survival, overall survival, and overall response rates were the secondary efficacy outcomes. Here, the point to note is that carboplatin was somehow used by AUC4, which is not very standard, and gemcitabine was used in the standard dose of 1 gram per meter square by day 1 and day 8. Next slide, please. So if we compare the median PFS, it was 8.4 months in the chemo plus placebo arm compared to 12.4 months in the chemo plus Bev arm, showing around 4 months of significant benefit in the median PFS in the bevacizumab arm. So it established the role of bevacizumab in the recurrent setting, in that platinum sensitive ovarian cancer patients in the recurrent setting also respond to bevacizumab when combined with chemotherapy. Next slide, please. Then coming to the GOG 0213 study, platinum sensitive recurrent epithelial ovarian fallopian tube or primary peritoneal cancer. One or less than one prior, up to one prior chemotherapy regime was allowed, including induction and maintenance. Performance status 0 to 2 patients were there. If the candidate is surgical, then again randomization was done to surgery or no surgery group, and if the patient is not surgical, then directly proceeded to randomization to chemo or Bev. So in the one arm, chemotherapy 3 weekly for 6 cycles and up to 8 cycles was given, and in the other, chemotherapy plus bevacizumab followed by bevacizumab maintenance. Here the carboplatin dose is the standard AUC5, Paclitaxel 175 mg per square meter, and bevacizumab was again used in 15 mg per kg dose 3 weekly. A main efficacy outcome of this trial was overall survival. Additional points were PFS and overall response rate. Next slide, please. So coming to the median overall survival, the graphs started to separate after a few cycles, after a few months, and 5.3 months increase in median overall survival was seen in the bevacizumab arm. Median PFS 13.8 months with Avastin, that is bevacizumab only, plus chemotherapy versus 10.4 months with chemotherapy alone arm. So around 3.4 months of benefit with in PFS, and around 5.3 months of benefit in overall survival was there with the use of bevacizumab. Next slide, please. So overall survival 37.3 months in chemo arm, 42.6 months in Bev arm, PFS 13.8 versus 10.4. Overall response rate, which was an exploratory efficacy outcome measure, 78% versus 56% in the chemotherapy arm. So hazard ratio of overall survival and PFS was significant, 0.84 and 0.6. Next slide. So Aurelia study, as we know, here the platinum resistant recurrent epithelial ovarian cancers patients were taken. Till now we have seen upfront and platinum sensitive use, but now platinum resistant cases were taken. Up to 2 prior chemotherapy regimes were allowed. PS status of 0, 1 and 2 were taken. There should have been no evidence of rectosigmoid involvement by pelvic examination or on CT scan, or there should be no symptoms of obstruction, bowel obstruction. So randomization chemotherapy selection was as per investigator. Paclitaxel, topotecan, and lipodox, all three agents were used. Randomization was done in the investigator choice chemotherapy one arm, and in the other arm, bevacizumab. Here the dose was 10 mg per kg 2 weekly or 15 mg per kg 3 weekly till progression. The doses of Pacli was used in weekly regime, 80 mg per square meter, topotecan 4 mg per square meter, day 1, day 8, day 15 4 weekly, and lipodox in the standard dose of 40 mg per square meter 4 weekly. Next. Coming to the progression-free survival, around 3.4 months increase in median progression-free survival was seen with the uses of bevacizumab. So bevacizumab works well in platinum-resistant cases also, as shown in this study. The graph started to separate very early in the first 3 months only, and the curves continued the separation, and the benefit was seen till the end of around 2 years. Next slide, please. So PFS, 6.8 months in Avastin plus chemotherapy compared to 3.4 months in chemo arm, has a ratio of 0.38. P-value is very, very significant. Overall survival, which was a secondary outcome measure, 16.6 months versus 13.3 months, around 3 months of benefit. And overall response rate, 28% versus 13%. Next slide. So incidence of paracentesis, because ascitic fluid filling, abdominal distension, and the need of therapeutic cytic tapping is a significant morbidity burden for the ovarian cancer patients. So absence of paracentesis after the first bevacizumab dose suggests that adding Bev to chemotherapy improved control of ascites. If we see this graph in the chemotherapy alone arm, in the first cycle around 7 to 8% of the patients required paracentesis as compared to 1-2%, and in the subsequent cycles the need was almost there was almost no need of paracentesis in the bevacizumab arm, as we already know that ascites is a predictor of response to bevacizumab even in induction, upfront, and all the settings. So here this correlates well. Next slide, please. So bevacizumab in ovarian cancer, summary, to summarize, there is a proven efficacy in newly diagnosed ovarian cancer patients, platinum sensitive recurrent ovarian cancer patients, platinum resistant ovarian cancer patients, and there is a improved control of ascites. So almost in all the settings of ovarian cancer, bevacizumab, the anti-VEGF inhibitor, has a role, and its role is also there to improve in the symptomatic relief of the patient, especially the ascites. Next slide, please. So coming to a very exciting phase 3 Mirasol study, mirvetuximab soravtansine versus investigators' choice of chemotherapy in platinum-resistant, advanced, high-grade epithelial ovarian, primary peritoneal, or fallopian tube cancers with high folate receptor alpha expression. Next slide. So FR alpha is in the focus from last few years in the ovarian cancer patients. So the background is that there are no randomized phase 3 trial has shown an OS benefit of a novel therapy in platinum-resistant ovarian cancer. Mirvetuximab soravtansine is an ADC, that is antibody drug conjugate, comprising a FR alpha binding antibody, cleavable linker, and maytansinoid DM4, a potent tubulin target agent. So FR alpha is expressed in about 90% of ovarian cancers, with 35 to 40% of platinum-resistant ovarian cancer tumors exhibiting high FR alpha expression of in more than 75% of tumor cells. So this agent MIRV demonstrated an overall response rate of 32%, median duration of response of 6.9 months in the single-arm study SORAYA of Bev pre-treated platinum-resistant ovarian cancer to support accelerated approval by the FDA. Mirasol is the confirmatory randomized global phase 3 trial designed to support approval worldwide. Next slide. It was an open label phase 3 randomized trial of MIRV versus investigator choice chemotherapy in patients with FR alpha high platinum resistant ovarian cancer. Key eligibility criteria were the disease should be platinum resistant, that is platinum free interval should be less than 6 months when the progression happened. FR alpha detected by ISC with PS2 plus intensity at least among more than 75% of viable tumor cells. So this is very important. The approval is based on this particular eligibility criteria. Primary platinum refractory disease patients were excluded. So again, a very important point, that only platinum resistant patients were there, neither platinum sensitive, neither platinum refractory. 1 to 3 prior lines of chemotherapy were allowed. Prior Bev and PARP inhibitor allowed. Patients with BRCA mutations were allowed. So in the experimental arm, MIRV 6 mg per kg 3 weekly was given. In the investigator choice, either Paclitaxel, Lipodox, or Tocotrican was given. Stratification factors by the agent of chemotherapy used. Primary endpoint was PFS as assessed by investigators. Secondary by overall response rate, safety, and tolerability. Next slide, please. So baseline demographic and stratification vectors were almost similar. Stage at initial diagnosis, around 60 to 65% patients were stage 3 and 1/3 of the patients were stage 4. Prior exposure of Bev was there almost in around 60% of patients. Majority of patients had PARP inhibitor also, and around almost all the patients had prior exposure of taxanes. Stratification, similar patients were there in each of the chemotherapy arms, and Beckley was there in around 40%, 35% in Lipodox, and in 23% Topotecan. Next slide, please. So primary endpoint was progression-free survival as assessed by investigator. Median PFS was 4 months in chemotherapy arm and 5.6 months in mirvetuximab, which may not be very significant, but there is some incremental benefit of around 1.5 to 2 months. Hazard ratio 0.65 and p-value is significant. The curves started to separate in first 3 months only, and the separation continued till around 24 months, which is the study period. Next slide, please. So best overall response as assessed by investigator. CR in few patients was achieved in mirv arm compared to 0 in chemotherapy arm. Progression, partial response was there in around 37% versus 16%. Stable disease was there in around 40% of the patients. Only 14% of the patients had progressive disease in mirv arm compared to 27% in the chemotherapy arm. Next slide, please. So progression-free survival 5.9 months. This is the PFS by blinded independent central review. 5.9 months versus 1.3 months, again showing a benefit of around 1.5 months. Hazard ratio 0.72, p-value 0.082, which is significant. And overall response rate 82% versus 33%. So BICR for PFS and ORR were concordant with investigator assessment. Next slide, please. Coming to the gold standard overall survival, median OS was 16.4 months in mirv arm compared to 12.7 months in chemo arm, again showing a benefit of around 3.5 to 4 months. Hazard ratio 0.67, p-value is less than 0.05, that is significant. Next slide, please. So progression-free and overall survival in bevacizumab naive and prior Bev treated subsets. So in the Bev naive patients, median PFS was 7 months in the mirv arm compared to 5.6 in the chemotherapy arm. Hazard ratio of 0.66. When the prior Bev was used, it is 4.4 versus 3 months. So both the subsets benefited, although the benefit was incremental in the ratio of around 1.5 months in PFS. Coming to median OS, around 6 months of median OS benefit was there in the Bev naive arm compared to around 4 to 5 months of survival benefit in the prior bevacizumab arm. Next slide, please. So patient-reported outcomes, patients that received mirvetuximab had a significant decrease in abdominal symptoms over 8, 16, and 24 weeks with a p-value that is significant. Next slide. Coming to the safety profile, adverse event, grade 3 plus adverse events were there in around 42% of the mirv arm compared to 54% in chemo arm, that is better in mirv. Discontinuation due to side effects was there in around 9% in mirv arm compared to 16% in chemotherapy. So mirv has a better tolerability as compared to the chemotherapy in this particular subset of patients. Next slide. Differentiated safety profile, treatment emergent adverse events, as we have seen, neutropenia, anemia, thrombocytopenia, all was lesser with the mirv arm. Peripheral neuropathy is lesser, alopecia is almost not there. Diarrhea is almost comparable, nausea and diarrhea is almost comparable to chemotherapy arm. Blurred vision can be a significant side effect, is seen in few patients, but the grade 3 adverse events were only in 8 patients. Keratopathy and dry eye. So ocular symptoms, we should be very careful when using mirv. Next slide, please. So to conclude, mirv is the first novel treatment to demonstrate a benefit in overall survival in platinum-resistant ovarian cancer in a phase 3 trial. Mirv demonstrated statistically significant and clinically meaningful improvement in PFS, overall response rate, and OS compared to investigator choice chemotherapy with a differentiated safety profile consisting predominantly of low-grade ocular and GI events. Mirv is the first ADC for ovarian cancer with proven efficacy, and this is the only FDA-approved biomarker-directed therapy for platinum-resistant ovarian cancer. These data are practice changing and position MIRV as a new standard of care for patients with FR alpha positive platinum resistant ovarian cancer. Next. So this is the actively recruiting clinical trials of immunotherapy for ovarian cancer patients. There is trial of Pembro and Len, neoadjuvant dendritic cell vaccination for ovarian cancer, systemic immune checkpoint blockade and intraperitoneal chemoimmunotherapy in recurrent ovarian cancer. There is trial of Durva plus tremelimumab and Pembro and platinum. So very large number of exciting new trials are happening. Maybe we will get more approvals in ovarian cancer with these novel ADCs and immunotherapies. Next. So again, continuing, there's PD-1 antibody combined neoadjuvant chemotherapy, oncolytic virus is there, Pembro plus supportive care in platinum-sensitive recurrent ovarian cancer, and newer molecules are there. Next. Thank you so much.
Thank you, Dr. Mukesh, for this, newer update as well as a review of the bevacizumab. As we all know that, stage 3 ovarian cancer is one which we deal day in and out, and unfortunately for the large part of 2 decades, apart from just PARP inhibitors, we didn't have any, newer therapies. So I think so with these ADCs coming up, and probably in near future we would be having them in our country too. So things look better both for the patients as well as the physicians. So thank you, Dr. Mukesh.
Thank
And
you.
now we move on to the next talk, which is on immunotherapy advances for gynecological malignancies in 2024. And for that, I would like to invite my mentor, Dr. Sachin Khurana, who is Associate Professor of Medical Oncology at AIIMS, New Delhi. And good evening, sir, and welcome.
Hi, Priyanshu. Thank you. Thank you very much. Good
Over
evening.
to you, sir.
Thank you. Let me share my screen. So, are my slides visible?
Yes, sir.
Yeah, thank you. Thank you. So I would straight away start my lecture. Thank you, Priyanshu, for giving me this opportunity. So immunotherapy, we all know, is now coming up in more or less all the cancers and coming in first line and in many of the cancers, and it has definitely changed the way we are treating oncology in uh, in this decade. So a bit of a background. There's always a complex interplay between tumors and immune cells in pathogenesis and prognosis of cancer. We all know this now. And immunotherapy is something, an innovative treatment strategy that modulates or manipulates the immune system to attack cancer. So this was a article published in NEJM long time ago, and it showed that even in ovarian cancer, it was seen that at the end of treatment, the patients who had more of intratumoral T cells, more of tumor infiltrating lymphocytes, their 5-year survival was much better as compared to the patients who didn't have these T cells. So, and it was a stark difference with 38% 5-year survival for patients who had TILs and 4.5% in patients who didn't have any TILs. So this was a preliminary evidence that immune system has something in it to play in the pathogenesis, not really pathogenesis, but overall outcomes of cancer. So not only in ovarian cancer, it was also shown in cervical cancer that presence of tumor infiltrating lymphocytes predict survival outcomes. So, uh, so what are the immunosuppressive mechanisms of the tumor microenvironment? Why do we need these molecules to kind of reactivate our immune system? So there are always a production of immunosuppressive cytokines by cancer cells. There is an induction of immunosuppressive cells such as Tregs in tumor, and there are induction of inhibitory molecules such as PD-1 on activated cells and PDL-1 on cancer cells or antigen presenting cells. When these two PD-1 and PDL-1 they combine, they inactivate these CD4 and CD8 cells, and hence the immune system or the immune power of our body against the cancer cells is suppressed. So So if we block these molecules by monoclonal antibodies, the immune response of T cells can largely be activated, thereby re-establishing the anti-tumor immune effects. These are we all know about these antibodies, which are being used in across different tumor types. So, but is there a biomarker for this response? There are some biomarkers, but none of them is a robust biomarker. Some of the biomarkers we all know include TMB, MSI high, PD-L1 expression, and high levels of T cell infiltration. Now, this was a bit of background of immunotherapy and the biomarker which we can use. Coming on to different gynecological cancers. So the most important advancement of immunotherapy I feel that it has come up in endometrial cancer. And this came up actually when we moved on from the dual scheme Bachmann's classification of type 1 and type 2 tumors to a molecular classification. So when this NGS and all came up, we saw that endometrial cancer is not just type 1 and type 2. So we have now classified endometrial cancer into POL ultra-mutated, MSI high, or which are called hypermutated, copy number low, which are mostly endometrioid, and copy number high, which are which are serous-like, and they have very important impact on overall outcomes of endometrial cancer, and the most important being the POL one, which have very good outcomes. What are these POL and MSI? Why they're important here? Because these two POL actually encodes the catalytic subunit of DNA polymerase epsilon, which plays a relevant role in DNA repair, and POL mutation or MMR impaired DNA MMR pathway, they create a lot of mutation in the cancer and hence formation of new antigens, and basically they invite immune response. So so it was seen that the MSI high, which is a condition of genetic hypermutability resulting from defective DNA MMR, it can be seen in up to 28% of endometrial cancers. And so what's the actual rationale of immunotherapy in endometrial carcinoma? It is being seen that in these two populations, POL ultra-mutated and MSI high, there is a high new antigen load, which I just described. It has also been seen that they have high levels of CD3 and CD8 tumor-infiltrating lymphocytes, higher value of PD-1 and PD-L1 expression. And as we discussed, these are all kind of biomarkers for response to immunotherapy. Based on this biological data, Keynote 016 was the first trial that established some role of immunotherapy in endometrial cancer. So what they saw that in non-colorectal dMMR cohort, 2 patients of endometrial cancer were included, and there was a very good response to immunotherapy. Finally, they realized that a pooled analysis of 5 multi-cohort single-arm trials of Pembro that enrolled patients with dMMR, they noted that an overall response rate of 36% in 14 patients of endometrial cancer. So this was an evidence of a preliminary activity, you can say, or maybe a preliminary evidence of immunotherapy activity in endometrial cancer. Finally, they did this study, Keynote 158, which was pembrolizumab and used in second line, those who have failed who have failed chemotherapy in the first line metastatic setting, and they noticed that in an MSI high cohort, 57% ORR was seen. So this was unprecedented as far as endometrial cancer was concerned in second line metastatic setting. And 8 CRs were seen. So that means, and it was quite safe. So no major, you can say, classical percentage of immune-related side effects, and that's all. So then so the activity was not that robust in the proficient MMR cohort. So they tried to induce something with by adding an anti-angiogenic lenvatinib, which is a multi-kinase inhibitor. And then they noticed that even in proficient MMR, when lenvatinib was used along with immunotherapy, they saw a response rate of up to 36%. So 36 to 37%. So that was the evidence of activity, irrespective of MMR status, be it proficient or obviously the deficient patients were responding better, but even the proficient patient responded when lenvatinib was added. So this is it was also noticed that the activity was seen across all the subtypes of cancer, and both MSI high and proficient MMR, be it PDA, PDL1 positive or negative. So this pembrolizumab then side effects were also manageable. These hypertension and all these were mainly because of lenvatinib. Otherwise, immune-related AEs were seen in 57.4%, but mostly were manageable, and most common was hypothyroidism, which we all know is manageable. That led to the approval of pembrolizumab plus lenvatinib for advanced endometrial cancer that is not MSI high or DMMR. If they are DMMR or MSI high, then there's no need for adding lenvatinib, as pembro alone induces very decent responses. But this was in second line, so they thought, why not move into the first line? And these two pivotal trials published in NEGM in last year, 23, and they evaluated role of chemotherapy plus immunotherapy in first-line metastatic setting. So the two immunotherapies were used. One trial, the Ruby trial was evaluating dostarlimab, and the other trial was evaluating pembro. So coming to the pembro trial, the scheme was fairly simple. It was a comparative trial between placebo plus chemo versus pembro plus chemo, and stratification factor used were most important was DMMR versus proficient MMR. So starking difference again in DMMR cohort, the median PFS was not reached in the pembro arm, and it was 7.6 months only in the Pecli carbo plus placebo arm, HR of 0.3, and significant difference in the two cohorts. Proficient MMR also, they saw activity, but it was the magnitude of difference between the two arms was not that much as in DMMR cohort. Then Ruby trial evaluated almost on the similar lines. Only the immunotherapy was replaced with the dostarlimab, and again in DMMR cohort the differences were stark. There were HR of 0.28 and significant difference in median PFS between placebo versus dostarlimab. Again in PMMR the magnitude was less as compared to the deficient MMR cohort. All comers showed an HR of 0.64, and overall survival benefit was also seen. Again, significant difference in DMMR, not so much in the proficient MMR cohort. All histological subgroups were benefiting from immunotherapy. So irrespective of whether they are endometrioid or serous or carcinosarcoma. And this is important. Carcinosarcoma is an underrepresented entity in endometrial cancer trials, and we always struggle what to do with this entity. And this one, at least, I think there were some patients included in this trial, and there was some benefit seen by adding immunotherapy. So kind of in preliminary evidence. When they also see how many patients of different molecular subtypes were there, and we had 1.25% of wholly mutated and 22% DMMR, TP53 22%, and no specific molecular profile was 54%. Now, why it is important is because in poorly mutant you can see the survival is so good that even addition of dostarlimab didn't do anything. It was 100% in both the arms. But so this is not because that immunotherapy was ineffective in this arm, because if you see technically immunotherapy should be more effective in a poorly mutant, because there are more mutations and more neoantigen load, but they inherently have so much good prognosis that there is no need to really add anything to the chemotherapy. Otherwise, other molecular subtypes, as we know that obviously in PMMR the magnitude was less, but in DMMR and also in TP53 mutation, which are a little more aggressive, we saw that benefit. And quality of life was also better. And the main differences between dostarlimab trial and the pembro trial were that non-intrametroid histology were more represented in Ruby trial. That was of dostarlimab. More evidence of using dostarlimab in non-endometrioid histology. And duration of treatment, there was a difference in duration of treatment. Otherwise, in DMMR cohort, if you see the outcomes, they were more or less same. So this has now led us to include immunotherapy in first-line metastatic setting. I would say we are still more inclined to use it in a DMMR cohort. I would personally say that you can use, if it's MSI high, definitely use immunotherapy. If it's MSI stable, maybe give chemotherapy initially and then use pembrol and imatinib, something like that. In the other line, that may give an overall survival similar to using immunotherapy in the first line, or maybe even more than that. But I think OS data is still premature. Maybe we'll see some more insights when more data is available. Moving on, cervical cancer. So this is also very difficult to treat entity. We all know, we all struggle when a cervical cancer recurrent case comes up. Nothing works, frankly speaking. Short-lived responses with chemotherapy. So obviously there was a lot of interest in using immunotherapy in cervical cancer. We have all seen in benefit of immunotherapies in other squamous histologies like head and neck and lung also. So it was again tried in cervical cancer, and in basket trial, KEYNOTE 158, 98 patients were treated with of cervical cancer who were previously treated, and 83% having a CPS of more than 1. Single agent pembrolizumab was tried in second line, and 12.2% responses. I know they don't look very attractive, but in cervical cancer, in after pegcilicarbo, frankly speaking, in metastatic setting, you don't have much to offer the patients. So based on this, US FDA did grant an approval in CPS more than 1 of PD-L1 after in the second line, so after failure of first line chemotherapy. So as in other cancers, immunotherapy was tried in the first line in combination with chemotherapy, and this was a trial which was again a simple design, pegcilicarbo or cis plus minus bev with pembro versus placebo. And pembro, the benefit of adding pembro was seen in almost all the subgroups, more so in CPS more than 1. So and after that, it was approved in with or without bev in first line metastatic cervical cancer. On similar lines, the Atezo people did a trial and they made bevacizumab mandatory. They designed a trial using Atezo bev. This was BEAT-CC study. Atezo bev plus pegcilicarbo versus placebo bev pegcilicarbo. Simple 1:1 randomization, primary endpoint PFS, and in the Atezo, and this was this was irrespective of PD-L1 status. So in fact, there was not even a stratification, if I'm not wrong, based on PD-L1 status. And there was a clear-cut benefit in the Atezo arm versus placebo arm. I haven't included the other study. Now, pembro has also been tried in another study in first line, not actually first line, in radical setting in combination with CTRT. Pembro being started with CTRT and continued as maintenance for 1 year, and it has shown a PFS benefit as compared to the placebo arm. And now pembro, in fact, has been approved to be used with CTRT and then as maintenance pembro in cervical cancer. So coming on to ovarian cancer, so what we have learned so far is that the response rates have been a bit dismal as compared to endometrium and cervical cancer of immunotherapy in ovarian cancer, varying from 5 to 22% in different studies. This was one of the trials, Ninja trial, where they evaluated Nivo versus GEM or PLD in platinum resistant setting, and there was no difference. It was a negative trial. both in terms of PFS and OS. Then this was phase 3 Javelin Ovarian 200 study, again in platinum-resistant setting, avelumab plus PLD versus avelumab versus PLD alone, no difference, again a negative study. Javelin Ovarian 100 in untreated patients, no benefit of adding avelumab to standard chemotherapy. Not even in any of the subgroup based on PDL1 status, not even no difference based on BRCA status. Then this was a study where atezo was tried in combination with pecli, carbo, and bev. Imagine phase 3 trial, again a negative study. No difference in either the subgroup of PDL1 positive population. So not even in OS. So, but what is happening in ovarian cancer? Why we are seeing good progress in in cervical or endometrial cancer, but not in ovarian cancer? We don't know the right answer, but what we have seen is that there is a subgroup of patients that might be benefited in ovarian cancer, and that is clear cell carcinoma. The reason being maybe that these tumors express PDL1 with frequent associated PD1 positive TILs. There is the gene expression profile are similar between renal and ovarian clear cell carcinoma, and we know that there have been good achievement with immunotherapy in renal cell carcinoma. So in ovarian cancer, clear cell may be that subtype which may benefit with immunotherapy, and the PEACOCK trial is evaluating the role of pembrolizumab in gynecology of clear cell carcinoma. And why we are failing in ovarian cancer? Maybe because maybe we are not able to find out the right biomarker, because there have been some responses, some durable responses, but we don't know who are these patients who will actually respond. MMR is one biomarker which can be used across all solid tumors, but otherwise in ovarian cancer we are still struggling to see immunotherapy coming up in a big way. So it may be a matter of disease biology, some immune evasion happening, some immunosuppressive cells, some suppressive cytokines leading to immune evasion. But the point is that we are still struggling, except that that I haven't included that trial. DUO study has shown some benefit of Durva added to olaparib as well as bevacizumab. They are giving everything. They have seen some benefit of using Durva plus olaparib as in the maintenance setting, in the maintenance setting in combination with bev. But I think as of now we are not very convinced with that data. But let's see how it evolves. So I think it will take some time before we are able to really point out any role of immunotherapy in ovarian cancer. Let's see how the road how the things behave ahead. But so the conclusions from my side: immunotherapy is an upcoming area of therapeutics. We all know encouraging results in different tumor types. Pembro has been used with and without chemotherapy in cervical cancer. Atezo is about to be approved. Pembro with or without lenvatinib, with or without chemotherapy in endometrial cancer. In ovarian cancer, we are still working on. We are still struggling, but possibly we will have some potential new biomarkers and combinations which are being explored. So that's all from my side. Thank you very much.
Thank you, sir, for this very insightful presentation. So I think so with the cost of IO now coming down pretty much, so I think so we might be seeing more of these drugs being used in our general population. And we now have, I think so, finite cost yearly for that because of that program. So, so what is your take? I mean, do you see a bright future in Gynec?
Definitely. I think, of course, you have pointed out right now. So I think we will learn more as we use more. So far, we haven't been used more because the cost was so high. So patients of cervical cancer, unfortunately, they are from poor socioeconomic background. So we always struggled with them. But now the cost coming down, maybe some biosimilars coming up, we'll be using more, and I guess we'll be learning more. And yes, I think we will be able to find a subpopulation of these difficult to treat cancers where immunotherapy can have a good role to play. So yes, we may be having a bright future. You're right, in gynec cancers. Yeah.
Thank you, sir. Thank you so much.
Thank you. Thank
I
you.
would like to have a opinion on if the patient has a PDL1 score less than 1. The data of the keynote trial showed that the subset was only 33 patients in cervical cancer where the PDL1 score was less than 1, and it still showed a benefit. So maybe we might be moving away from PDL1 testing in cervical cancer after some time. This may also happen because we have seen in most of the squamous sites, wherever we see squamous cell carcinomas, immunotherapy does work better than only chemotherapy. So adding immunotherapy may be a better idea. Yes, as sir has already said, looking at the responses, learning when we tend to use more of these drugs will be a better thing.
Absolutely, absolutely. In
Definitely.
fact, I have used irrespective of PDL1 in certain patients of cervical cancer, and they have shown response. There's no doubt about that. So I think we'll learn, as I said, as we learn more as we give more.
Yes, yes.
That's true. Yeah.
Even I have started on outpatient.
Yeah,
That's what
that's
I have had a discussion with the patient.
Of course, yeah.
Okay, thank you, sir. Thank you, Dr. Sachin.
Thank you, Priyanshu. Thanks a lot.
So now we move on to the next session, which the next talk is, we'll start with the breast cancer session. The next talk is on monarchy, molecular profiling of primary tumor tissue and ctDNA detection in patient with high risk, node positive, hormone receptor positive, HER2 negative early breast cancer treated with adjuvant endocrine therapy with or without abemaciclib. And for that, I would like to invite Dr. Nitish Garg, who is Assistant Professor Medical Oncology at AOI DMC Ludhiana. So over to you, Dr. Nitish.
Thank you, Dr. Priyanshu, and thank you, organizers, for this opportunity. So let me start sharing my presentation quickly. I hope it's visible. Okay.
Yeah, it's visible.
Okay, so well, it's a long topic to read. Again, it is basically the molecular profiling of the primary breast tumor along with the ctDNA in high risk node positive, HER2 negative, hormone positive EBC treated patients with hormone therapy plus minus abemaciclib. So basically, we all know what is the background of monarchy, where it has shown that the responses have invasive disease-free survival at 5 years have improved to the tune of 7.6% compared to only endocrine therapy in high-risk patients where the number of nodes were positive more than 4 or the size of the tumor more than 5 plus 1 to 3 nodes which are positive. Along with that, then there were certain subsets which they tend to evaluate. So this current analysis of this trial has been done to find out which molecular subset of these patients have a better outcome. Again, it is not a primary endpoint of this trial. It was a secondary endpoint, and then again the subgroup analysis. Then out of that, there was a small pilot study which was evaluating the technical feasibility of circulating tumor DNA and what is its relationship with the recurrences and the predictive values. So this is the overall study design of this Monarch E trial, which was a randomized phase 3 trial. Again, the patients may be pre or post-menopausal, high-risk patients who are node positive, hormone positive, HER2 negative, prior neoadjuvant or adjuvant chemotherapy is permitted. The cohorts were intention to treat population. Cohort 1 had 91% of the patients who were more than 4 lymph nodes positive or 1 to 3 lymph nodes with a tumor size of more than 5 centimeters. Cohort 2 was only 9% of the patients where it was 1 to 3 lymph nodes positive with P67 index of more than equal to 20%, and the tumor size is less than 5. So they were divided, randomized to abemaciclib given BID dosing for 2 years plus endocrine therapy for 5 to 10 years versus only endocrine therapy. So as I mentioned, primary endpoint was IDFS, which 5-year data has shown that there is a benefit of giving abemaciclib in the intention to treat population. The secondary endpoints were IDFS in the E67 high population, then disease reoccurrence-free survival, overall survival, and the PROs. Then came the current analysis is the molecular profiling. So when this was the case cohort designed to evaluate the treatment effect of abemaciclib plus EP among the 6,000 patients. Out of those 6,000 patients, 1,400 patients were taken, and this population was divided. The biomarkers which were analyzed were the initial basic ones: luminal A, B, HER2 enriched, and the basal-like or the basal. And the other biomarkers which were analyzed was E67 index, then oncotype DX, and the whole genome sequencing along with RNA sequencing of the exome capture. So this was the overall design setup, and this whole genome sequencing and RNA, as we do in lung, as we do in colon, it tends to find out the mutations, the deletions, the structural variations and fusions or RNA subtypes which has happened. So fairly well matched profile of the trial. So not a great difference. So when we looked at the intention to treat population and the biomarker analysis, in almost all the subsets, the hazards ratio is approximately 0.7. So which had shown that whatever biomarker it may be, or there might be any difference or any mutation, everywhere abemaciclib along with hormone therapy is going to benefit. So look at the 4-year IDFS rate. There was a benefit with abemaciclib with whatever biomarker we are testing for. So coming to the molecular profiling, when luminal A, B, HER2, and basal were tested, so these are the basic parameters what we do. So luminal A and B in both the areas had a significant benefit. HER2 enriched and basal, definitely there was a benefit of abemaciclib, but this trial did not include those patients who were HER2 enriched, only a small population, so we cannot comment too much on this. So the molecular subtype assignments and the RNA expression of ER/PR HER2 comparable between the monarch biomarker subtype and the genome cohort and the total genome cohort. So in both the arms, the 80% of the tumor, the patients were in luminal A and B, and again the responses were almost similar as the intention to treat population with the hazards of 0.7, except for in luminal B when you see the hazard of 0.6, where the responses tend to be slightly better. So then they evaluated or inferred how oncotype DX scores help us choose abemaciclib. Does a score of more than 25 help us choose it better, or if it is less than 25? So looking at this table here, the IDFS at 4 years was improved in both the scenarios, even if the score is less than or equal to 25, or if the patient has a high score of more than 25. So the difference again was to the tune of 8 to 9% in both the arms. So there was a benefit in oncotype based biomarker also. Irrespective of the biomarker, we can still give. So looking at the whole exome sequencing and the RNA profiling, so this shows if the patient had a PIK3 mutation or a PIK3 which is wild type, there is still a benefit. So looking at abemaciclib, the prevalence was to the tune of 38%, and abemaciclib patients were 26, and the ET patients were only 32. Almost the same, similarly matched population. There was responses in almost all of the areas except for when there is MYC amplification. MYC amplification, because we know it can increase the CDK4/6 in an independent way. So the effect of abemaciclib comes down. So that is why the benefit of abemaciclib in MYC amplification was not seen, and otherwise in rest of all of the mutations it was seen. So this specific profiling was done when the patients have the prevalence of mutation was more than 9%. If the prevalence of mutation was less than 9%, those mutations were actually removed out because they are not the commoner mutations. So these are the few commoner mutations which were taken, and MYC amplification was one of them, which showed something different, and definitely we know what was the reason of it. So this in this analysis of the biomarker subtype, participants with node positive, high risk hormone receptor positive, HR negative, abemaciclib plus endocrine therapy improves the DFS across the molecular subtypes and inferred oncotype RNA risk scores versus ET alone. So the benefit was all over the population except for the MYC amplification. So this maybe still needs to be evaluated further. Does the graphs are having a plateau after some time or not? And investigators concluded that the analysis supports the use of abemaciclib plus endocrine therapy in node positive for high risk hormone receptor, irrespective of the molecular typing. So, and again, the same line, as I said, MYC amplification needs to be evaluated further. So coming to the next analysis or the pilot study pulled out of this same trial, which was the feasibility of ctDNA. So the patients who were selected were to the tune of 180, and they were evaluated based on the whole genome, whole exome sequencing from the primary tumor. So this tumor sequencing was done at a plasma collected at 0 month and then 24 months. So this was the usual test performed is by a Signatera circulating tumor DNA assay, where, as I mentioned, the 16 gene variants which were commonly seen were evaluated out of the whole of the sequence. So coming to the recurrences, if we see on the the right hand side, a patient who has a ctDNA positive at 0 months, the chances of recurrence are high. So if the patient have a ctDNA negative, the chances of reoccurrence are slightly lower. So, and if the patient had a ctDNA positive at 24 months at the end of therapy, there is definite indication that it is going to reoccur. Almost all the patients out of 42, all the patients have reoccurred, so positive predictive value of 100%. And if they have negative, the negative predictive value is to the tune of 79%. So this is what was shown in this the table on the left hand side, that patients who remained ctDNA positive, if it was on the same level, they were controlled to a certain extent, and if the patients have been cleared, the responses have been great and the reoccurrences have been less. So in this pilot study of ctDNA detection in subset of monarch E patients, ctDNA status at 24 months was a predictive of reoccurrence with a positive predictive value of 100%. 21% of the patients persistently having ctDNA experience reoccurrences. And the investigators concluded that negative predictive value needs further improvement and clinical utility of the ctDNA detection remains to be determined. Thank you.
Thank you, Dr. Nitish. So we move forward, and for the next session, which is sponsored by Novartis. So I'll like to invite Dr. Kunal Jain. So sir is assistant professor in the Department of Medical Oncology, AOI Ludhiana, and sir will be talking on dilemma of choosing a CDK4/6 inhibitor in first line metastatic breast cancer setting, reality or myth. So over to you, sir.
Thank you. Thanks, Priyanshu. I hope I am audible.
Yes, sir. Yes, sir.
Great. So I think Nitish has already given a good overview of one of the molecules that we are using now for metastatic, as well as more so, I would say, in early breast cancer, CDK4/6 inhibitor. Now we are spoiled with choices as to what to offer to the patients. So that is what we are going to discuss in the setting of metastatic breast cancer, because that is where dilemma is. Right now, thankfully, I think for early breast cancer, things are more or less settled. But for metastatic breast cancer, what do we do when a new patient comes with metastatic breast cancer and has hormone receptor positivity? Okay, so I think looking from the patient's perspective as to what are the treatment goals, this paper basically looked from the patient's point of view as to what is it that they want. So in terms of various points, they were supposed to rank what is the most important from their perspective. And not surprisingly, majority of the patients wanted to prolong their life as the major goal, and which was followed by improving their quality of life and also to preserve the quality of life as a third thing, that third most common thing decided by the patients. And in terms of second best option, again, the quality of life issues were ranked higher. And as the third choice was to delay chemo and the symptom relief. Again, highlighting the fact that from the patient's point of view, improving, prolonging their life and improving the quality of life are the most important things. And again, this paper published in 2022 was basically highlighting the same thing, that for most women with advanced breast cancer, survival was their priority. And they were ready to trade off some side effects for extra years or months of life that they would get out of the treatment. And there is always a debate as to what is the ideal endpoint. We keep debating in the early breast cancer also whether IDF is the right endpoint. So in metastatic breast cancer, most of the trials will be focusing initially on PFS as the endpoint. But we know, as we talked from the patients, saw from the patient's perspective, overall survival is the gold standard. And it is defined as time from randomization until death from any cause and is measured in the intent to treat population. So this is the most reliable cancer endpoint. And when studies are conducted and they prove that OS has been achieved or benefit has been seen in overall survival, I think they kind of become the landmark or gold standard in that particular category. We do take PFS as a surrogate for a lot of diseases, especially in metastatic setting and also in breast cancer. And this is basically a paper which was analyzing 72 studies in advanced breast cancer. And what they were seeing was whether there was any correlation between PFS and OS. So what that means is, if a study is showing a benefit in PFS, does that translate into OS benefit or not? So not all studies were in that regard. So not all were positive studies anyway. And as you can see, there were studies where even PFS was more than one and OS was also more than one. So if we concentrate on the left half of this graph, even there were studies where PFS was much better, but they failed to meet the OS, which is what we commonly see, because now a lot of cancers, especially the breast, have become or are becoming a chronic type of disease, irrespective of the type. If we leave the triple negative subtype, I think both hormone receptor positive as well as HER2 enriched, we are talking in median survival of about 5 years or so. So they are more or less becoming chronic diseases. So if we now come back to this category of metastatic breast cancer, hormone receptor positive, and we look at the options that we offer to those patients in terms of hormonal therapy, we have 3 CDK4/6 inhibitors at our disposal. And there are studies to back all of them. We have the Mona Lisa group of studies for ribociclib, including all categories and using both AI and fulvestrant, and similarly for abemaciclib, Monarch 2 and 3, and for palbociclib, Paloma 2 and 3, where post-menopausal patients were offered AI, and for Paloma 3, fulvestrant was combined with palbociclib. So all these studies showed that there was a significant improvement in progression-free survival, and if you see the hazards, they are almost similar, close to 0.6 in all the studies. But majority of these studies, especially the Paloma and Monarch 3, failed to show the OS benefit, whereas ribociclib in all the categories, whether it was post-menopausal in combination with AI in first line, or in combination with fulvestrant, or in pre-menopausal, where we would give GnRH analog and then give AI and CDK4/6, all of them showed significant improvement in OS as well. So, and Monarch 2 obviously showed that there was improvement in overall survival also. So the idea behind this discussion is to tease out what are obviously this is some of these will be cross trial comparisons, which are not ideal, but we're trying to understand as to where is the difference. Is there any difference really, or is it just by chance? So if we see the Paloma 2 and 3 studies, both of them showed PFS benefit. As I said, the hazards are quite impressive for PFS, but when we go to OS, you can see the curves in Paloma 2 are almost intertwined with each other. Some separation in Paloma 3, but not statistically significant, with a hazard of 0.8. Then what could be the reasons for these differences? So either it is different patient population, which is the case in some of the studies, whether the patients in different studies got different treatments once they progressed, or are these drugs really different by themselves? So if that is the case, and I think then it is a strong case for one drug over the other. So if we see the various trials, taking only the ones where AI was used as the first line in combination with the comparator CDK4/6 inhibitor, majority of these trials are kind of more or less as per the different patient population. They are kind of similar. Randomization was different in both Monarch and 2 and 3 and Paloma. It is 2:1 randomization, whereas in Mona Lisa it is 1:1 randomization. And prior chemotherapy obviously was not allowed in either of these. Treatment free interval was a bit different. Slightly lesser percentage of patients had less than 12 months of treatment-free interval from the previous adjuvant or neoadjuvant treatment, mostly adjuvant hormonal therapy. It was about 17% in Mona Lisa and about 22% in the Paloma study. And if we talk about Monarch studies, we will see later, they mandated that the treatment-free interval should be more than 12 months. So no patient with less than 12 months of treatment was included. So just trying to tease out, I think these are statistical maneuvers. We may or may not get too much out of it, but this is something that they had done to look at if we match the patients in the Mona Lisa 2 study as they were in Paloma 2, there were slight decrease in the number of patients. You would take out the patients who do not fit into that eligibility criteria, and then by waiting you will match and reach close to that number. And then what they were trying to tease out, that if we do that analysis in spite of keeping the Paloma 2 eligibility criteria, there was still a statistically significant difference in overall survival, which was in fact favoring ribociclib over palbociclib. So this adjusted analysis also showed, matching adjusted analysis, that ribociclib possibly was better than palbociclib. And if we see these two studies, Monarch 3 and Mona Lisa 2, as I said earlier, there was a mandate that patients would have progressed after 12 months or more than. There should be more than 12-month gap between their last hormonal therapy before they could be enrolled in Monarch 3, whereas in Mona Lisa 2, almost 18% of patients had a treatment-free interval of less than 12 months, which was the prior hormonal therapy. So again, if we match these two factors, as we did for palbociclib and for Mona Lisa, if we take out those patients who had a shorter treatment-free interval previously from the Mona Lisa study, you can see the magnitude of benefit, in fact, increases for that category. So which we would expect, like if we take those categories of patients who we classify as endocrine resistant, you would expect a much higher magnitude of benefit if you are giving taking endocrine sensitive patients only. And as the second point from the patient's perspective was quality of life, I would say majority of these drugs now we know how to handle them. I would say abemaciclib has possibly the worst tolerance, but that is if we know how to handle the drug. It is initially 8 to 10 weeks which are more troublesome for the patients, and once that phase is over, majority of the patients' diarrhea, which is the major problem, can be easily handled, and it is hardly a problem. Fatigue is a common problem with all of them. Cytopenia is more with the palbociclib, and as you can see with ribociclib, the quality of life information or data is quite well preserved. We know that two other factors that we have to keep in mind are liver toxicity and QTc prolongation. That is not from the patient's point of view, but as from the lab parameters that we keep monitoring. Again, this slide is basically trying to show that patients are able to make a judgment, or they can say that some of the side effects they are able to bear with additional benefit derived from the drug. So side effects are acceptable to them if they see that there are more benefits with that drug. But some of the patients obviously are not willing to tolerate the fatigue, pain, diarrhea, or loss of appetite, even if the treatment was effective. It is a personal choice from the patients. So similar analysis, the matching adjusted analysis in ribociclib, if we take ribociclib and abema, the overall symptoms were in favor of ribociclib as compared to abemaciclib. So looking at the drug as a whole, we know ribociclib and palbociclib have less off-target blockage of CDK4, other CDK4 as compared to abemaciclib, which has a kind of a much wider coverage. And we know that these cell lines or the CDK4 are more expressed on endocrine receptor positive cells. Ribociclib and abemaciclib are more active against CDK4 than CDK6 in both CDK dependent cell lines and in biochemical assays. And I would say maybe we know abema is 12 times more potent blocker of CDK4 than CDK6. So that leads to differential toxicity. The cytopenias are less with this as compared to palbociclib. And that is why we can give abema also for a continuous duration as compared to the other, where we have to give an interrupted dose. So as I mentioned earlier, these two drugs, ribo and palbo, have fewer interactions with off-target kinases. That is why more toxicity with the abemaciclib also. And at clinically relevant doses and after adjustment for differences in potency against CDK4, ribociclib is expected to provide greater CDK4 inhibition, so at the lab level. So this is again an interesting cartoon, basically trying to depict that the initial tumor subtype may gradually change as we put the patients or subject the patients to various treatments, especially the hormone dependent or the initial HER2 enriched may increase over time, whereas triple negative hardly change. Luminal A may decrease and luminal B also may increase. This is what is presumed to happen when we are giving treatment with ribociclib. And contrary to this effect, when palbociclib was studied, there was in fact an increase in HER2 enriched and significant decrease in luminal A and also in endocrine sensitivity in the palbociclib treated patients. So what happens when we are giving first line treatments? What are the subsequent therapies? We all will give second line hormonal therapies, and in some cases, straight away, if we are not getting adequate responses, early progressors may be candidates for chemotherapy. So what the studies on ribociclib showed that the subsequent treatments in those studies were also longer. The second line treatment would also be for a longer duration, with possible some carryover effect is what was proposed. And that was not the case with the palbociclib, where that kind of carryover effect was not there. And the second line treatment options were also not that durable. Now, looking at the guidelines, we all follow or look up to NCCN guidelines from time to time. And if we look at category 1 recommendation for metastatic breast cancer patients, ribociclib in combination with the AI, or ribociclib or abema in combination with fulvestrant are the category 1 recommendations currently. And looking at the magnitude of clinical benefit scale given by ESMO, again, ribociclib in various combinations scores over other CDK4/6 inhibitors and other PIK3CA inhibitors and everolimus. So in summary, the 3 CDK4/6 inhibitors that we have are different due to their pharmacokinetic and pharmacodynamic profiles. Ribociclib has highest CDK4 versus CDK6 selectivity and least off-target inhibition. This has highest free drug concentration and potential impact on tumor biology, leading to improved endocrine sensitivity and hence improved prognosis. This is one of the hypotheses, and a potential carryover effect post progression. This is the only CDK4/6 inhibitor to significantly improve OS across lines of therapy, endocrine partner, or menopausal status, whether it is pre or post. And this has maintained or improved quality of life in all the trials. So only CDK4/6 inhibitor to be recommended as a category 1 recommendation in NCCN in combination with either fulvestrant or with AIs. And again, just to emphasize again that quality of life benefit, which is something important from our point of view also, and also from patients, is maintained by ribociclib. And we have data that if there is progression on one, although it is not very robust, but there is some data in terms of maintained trial that majority of those patients got palbociclib in first line and they were given ribo in second, and they did derive benefits. But the talk here was mainly for the first line setting. Thank you very much.
Thank you, sir. So for now the difficult questions of what is a real life practice. I mean, cost would definitely come into being with generic, palbociclib coming. So rather than giving nothing, do we give preference to palbos sometimes if the patient is, not affording, though the OS data is not that good with palbo?
Correct. I think we also have results from the SONIA trial, but I think the majority of the patients in that study, almost 85% or 90%, I don't know exactly, but in excess of 80% got palbociclib. So what that study showed that if you do not give CDK4/6 inhibitor in first line, you reserve it for second line, your PFS2 is kind of similar. So survival may not differ as long as majority of them will get CDK4/6 inhibitor in the second line. So in my practice, yes, majority of the patients do get palbociclib as first line, mainly because of the cost. But if somebody is affording, understanding of the benefit, or they are understanding of OS benefit, I do offer ribociclib. But the number is less, I would say now.
And so what do you think, does the real world PFS match the trial level with ribociclib? Because for me, I think so. A lot of my patients have reached or crossed 2-year PFS with ribo. So what is your personal experience?
Yeah, I have patients on ribociclib who are on ribociclib for in excess of 4 years. But when we are talking about median, it means that out of 10, at least 5 will reach that mark of about 20 months, 24 months. But there will be some who will be progressing within 6 months, or I have had patients on ribociclib who would progress um, on that drug for after 6 months, 7 months. Inherent tumor biology, maybe not that strong ER positivity. If it is checked from another lab, you are surprised to see that receptor positivity may also differ sometimes from lab to lab.
Thank you, sir. Thank you so much. After this session, now we move on to the next talk, which is by Dr. Rajat Bajaj, who is Director, Fortis Hospital, Noida, and he'll be speaking on Alexandra trial. So welcome, sir. Over to you.
Hello, am I audible?
Yes, sir, you're audible.
Yes, sir.
So I thank
Sir, your voice
and I
is audible
also,
actually. Rajat sir.
is it better now?
Yes, sir, it's better now. Sir, your voice
Yeah,
is not
so
audible.
I would want to start. Is it better now?
Sir, speak again.
Can anyone please confirm?
Yes, sir.
Is it better now? Okay, is Dr.
Yes, sir,
Kunal
it's
still
better
around?
now.
No, sir is not around. Sir is around. I mean, his video is not on.
Hello, can anybody confirm if Dr. Kunal is there? Dr. Priyanshu?
Yeah, yes, sir is there, but his video is not on.
Acha. Since we are discussing CDK4/6. Okay. Since we were discussing CDK4/6, so I wanted to ask him whether he's had any experience of absolute failure of CDK4/6 in the first line, or anybody else can take up this question, Dr. Priyanshu, or anybody else.
Sir,
Yeah,
I've had. Sir.
Yeah, go ahead, Priyanshu first.
Yeah, so I had one patient with a lot of liver metastasis who did not actually do well and progressed within probably 3 to 4 months, and not she was not willing for chemotherapy. I've had only one of this kind of patient.
So was there any reason that you could find out for the same?
We didn't have, so the patient deteriorated rapidly actually, so we couldn't rebiopsy it.
Okay.
And
Okay.
probably some ESR1, if you think, or some primary
ESR1 would
mutation.
still be okay. Dr. Kunal?
Yeah, as I was mentioning there, not all patients derive benefit from because the time of assessment also, Priyanshu has mentioned about a patient who had, I think, widespread liver metastasis, where also we would sometimes use CDK, but majority of the times those patients would end up getting chemotherapy. But what my experience was not in such a scenario, but routine majority of the patients lower visceral bulk, but majority of them the disease in bones, and you would and the breast primary, of course, and patients not responding. And
So,
the would be, I would say, maybe 1 or 2 out of 10, 20%, 10 to 20%.
yeah, so of course the response rates in all these trials have been to the tune of around 65 to 70%, which would mean that according to these trials, there are 30% patients who would not respond. And all of us can agree to the fact that these molecules are such that once we have a HR positive, HER2 negative starting on CDK4/6, even if it is a generic palbociclib, we are all very gaga about it. We always tell the patient that, you should not worry at all. These drugs are going to take care of all your misfortune events that have happened with you in the last few days or weeks. But then once that fails, it is quite a unfortunate event for everybody, including the clinician. So this has happened to me at least 3 to 4 times now. 3, 4 patients have been such. And I happened to read a very good article, and it was actually presented first as an abstract in ESMO 2022, which said that there are, out of the patients who actually have a failure of first line CDK4/6, that is progression, absolute progression on CDK4/6, 80% of them would fall into the bracket of 3 mutations. One of which we all know is PIK3 mutation. The other is a CCND1 amplification, and third was very interesting, which was HRD positive. So of course they did not look at BRCA per se, but looked at HRD, and HRD positive also was a PFS of only 5 months, so which was of course the on treatment progression. So of course we don't do but I think we should do BRCA and try to tell these, still send them on, probably tell them. Can I start my topic now?
Yes, sir.
Okay, right. So again, I thank the organizing team, and the topic that has been given to me is IMpassion 030, which was a phase 3 trial of adjuvant chemotherapy. In addition to that, atezolizumab, which we all know is a PD-1 inhibitor for stage 2 and 3 triple negative breast cancer. Next slide, please. So the basis of this trial was that there was definitely some evidence to suggest that the addition of atezolizumab to nab-paclitaxel in patients of metastatic breast cancer does improve the progression-free survival. And it was more so in the PDL1 positive subset, although we all know that there was an accelerated approval given by US FDA, which was later withdrawn because it could not be proved in the phase 3 study. But still, one has to remember that the DCGI approval is still on in PDL1 positive patients. Anyway, this of course is not a metastatic breast cancer trial. It is an early breast cancer trial that we are talking about, which is IMpassion 030 or Alexandra. And it was, when it was designed, the optimal timing of usage of immunotherapy in triple negative breast cancer, early breast cancer patients was not known. So there were trials of neoadjuvant setting and there were trials of adjuvant setting, all of them going on at the same time. Also, like I said, that the 031 trial was the addition of atezolizumab to neoadjuvant chemotherapy in triple negative, also had shown a significant PCR benefit till that time. So there was a postulated theory that probably once the patient has had a surgery, addition of atezo to the ongoing standard chemotherapy may bring in some improvement in probably EFS or for that matter OS as well, and that is why this study was conducted. The trial schema was designed. Next slide. So this is the trial schema, the randomized open label phase 3 study that we're talking about. Patients who were resected as stage 2 and 3 triple negative breast cancer, around 2,000 odd patients, in excess of that, and more than 50% were node positive. Very interesting because they had good volume disease. That means they were stratified by the nodal status, the surgery which was done, the tumor PDL1 status, into induction treatment and maintenance. So the induction treatment had to be in the control arm chemotherapy, followed by maintenance being just monitoring visits. And the induction treatment in the chemo plus immuno arm was atezo in the dose of 840 milligram Q2 weekly, that is to match with the chemotherapy, and up to 10 doses. Followed and along with that, the chemotherapy was paclitaxel weekly, followed by a dose dense AC or a EC, which is a standard thing in triple negative, followed by atezo maintenance, and this was completion for 1 year. The primary endpoint was kept as IDFS, and the secondary endpoint was kept as IDFS in the PDL1 positive, whereas primary endpoint was IDFS in the intention to treat. And along with that, the secondary endpoints did involve the overall survival and the disease recurrence free survival, along with disease free survival as well. Next slide. Now, these are the baseline characteristics, and important to understand that the median age was nearly the same in both the arms, which was about 53 in triple negative, that is about okay. Then 50% of these patients were whites. Most of these patients were ductal carcinoma, which is understandable. And histological grading, it was interesting to note that most of these patients had a poorly differentiated grade, and it was similar in both the arms. Most of these patients had a T1, T2 status, and T3 were very less. But if you look at the nodal status, 50% of them had a node positive disease. So they did include a fair bit of high volume disease patients, or so-called node positive station. Once the patient has had a surgery, the role of adjuvant chemotherapy is very important. That is why they want to see whether a patient, where by convention now we would use an NACT in the beginning, if they have been resected upfront, can we do something more than chemotherapy by adding immunotherapy so that we can improve the survival of these patients, especially when these patients are young patients. They are less than 60 mostly, and the median age here as well was less than 55 also. And most of these patients, if we see, they had a positive status as far as the PDL1 was concerned, which was in excess of 70% of them in both the arms had a PDL1 positive status. Next slide. So these particular things tell us that it was a well conducted study. The intention was right to see whether something more can be added to the known standard of care chemotherapy to bring important point to remember. Despite all that they did in terms of adding atezo to the ongoing chemotherapy, there was no improvement in the IDFS in the intention to treat in the PDL1 positive population, and in the OS in the intention to treat as well. The hazard ratios one can see are crossing 1. Even the p-value is not significant. So after a median follow-up of 25 months, a futility was declared for the primary endpoint of IDFS in the intention to treat population, and the similar outcomes were observed across all. Next slide, please. Now, if you look at the safety was probably was similar to what we know in the immuno plus chemo combination arms, and the IRAs were seen in the immunotherapy arm, which is obvious, but then by and large, nothing more than what we already know. Next slide. And there were IRAs in the atezo arm, rash, hepatitis, hypothyroidism. They were there, but they were primarily low grade. Next slide. So what it tells us is that still 2024 one should look at the use, which is the standard of care after the adjuvant addition of immunotherapy to the adjuvant chemo. IDFS in the even in the PDL1 positive subgroups, they were same. This was a combination which was well tolerated, although, but then it is certainly not in this particular subset of patients. The scenario of using it in the adjuvant setting probably is not something which is going to work. So we do learn from negative trials as well, and this was a learning that in the neoadjuvant setting, this approach should be used, and patients should be counseled that this is the way to go ahead. That is the neoadjuvant approach as far as the immuno plus chemo combination is concerned. Thank you so much for your patient listening. Back to the organization.
Thank you, sir.
So for the next session sponsored by Zydus, and I would like to invite Dr. Priyanshu Chaudhary sir to give us the talk, sir.
Can you share my slides?
Yashika, please upload the slide.
So please wait for 1 second. I'm doing it.
Yeah, sure, no issue. Yeah. So the talk today given to me and the slides that have been provided by Zydus is for response-driven management of HER2 positive early breast cancer fueled by updated data of TDM1. Next. So we all know the prognosis of HER2 positive disease is poor without HER2 targeted agents. So here we have the the graph which shows how patients who have been put on only chemotherapy, the locally advanced subtypes, they how they perform according to their luminal status. We see the luminal A are doing good, luminal B a little bit worse than that. And if we look at the HER2 positive and the basal like, so they are doing pretty bad with respect to overall survival with chemotherapy alone. So there's a strong correlation between the amplification of HER2 and poor clinical outcome. The HER2 positive showed much shorter disease-free interval, and the time to develop distant metastasis was worst for basal and HER2 positive. Next. So far, US FDA has approved 8 HER2 targeted agents. If we look at the ones acting on the surface, the first one was trastuzumab 1998. Then we had the intracellular domains. If we see in 2007, it was lapatinib. Then came pertuzumab into 2012. Then we have had TDM1, neratinib, tucatinib, margetuximab, and the latest one is the TDXD. Next. So anti-HER2 agent trastuzumab has done well as an adjuvant therapy. Next slide. So adjuvant trastuzumab improves disease-free survival and overall survival for patients with HER2 positive early breast cancers. So these are the landmark studies, that is the HERA study, the NSA BP B31 and the BCIRG 006. So with long follow-ups of up to 11 years and thousands of patients. So if we look at the disease-free interval, the disease-free survival, incremental benefit of 6.8% with the addition of trastuzumab to chemotherapy in the HERA trial, 11% in the B31, and 6.7% with the BCRIG 006 trial. Similarly, the OS benefit also 6.5% with HERA, 9% with NSPP B31, and 7.2 with BCIRG 006 trial. So trastuzumab with treatment with adjuvant trastuzumab after chemotherapy is associated with significant clinical benefit both in disease-free survival as well as overall survival. Next. So, but there's still a risk of recurrence which still needs to be minimized in HER2 positive early breast cancer. Next. So, how do we define the high risk HER2 positive early breast cancer patient with HER2 positive EBC who have a risk of more than 10% for recurrence? And after appropriate neoadjuvant chemotherapy and anti-HER2 therapy, if there's any residual disease, non-PAT CR, and after surgery, no neoadjuvant have been given, so any node positive disease or T3 T4 with any node. Next. So how can we personalize our approach to reduce the recurrence rate? Next. So the first is the neoadjuvant therapy. It is a move towards personalization. So neoadjuvant therapy response can guide us for improving the outcomes. If there is a PAT CR, we know that we are assuming that the micrometastases have also been cleared off, so the risk of relapse and overall survival is higher. The PAT CR patients who achieve a PAT CR have a better overall survival than those who have a residual disease. The patient who have a residual disease, they have micrometastasis, and which leads to later on disease recurrence and a poor DFS and a poorer OS. Next. So PAT CR is very important surrogate marker, and the disease-free survival and overall survival has been shown to be better with patients who have PAT CR. So in these trials, we see the DFS percentage for PAT CR versus non-PAT CR. In the Techno trial, we see a PAT CR patient 88% versus 73%. The Japar Quinto again 90% versus 83%. Neo Alto 86% versus 72%. NSABP B41 90% versus 81%. Neosphere 85% versus 76%. So the achievement of PAT CR leads to a longer disease-free survival and a better clinical outcomes. Next. So neoadjuvant therapy, which patient should be considered? Next. So for that, we have two kind of patients. One who are actually non-surgical candidate at presentation and are potentially operable or inoperable, like inflammatory breast cancer, bulky or matted N2 disease, or N3 disease, or clinically T4 tumors. While patients who are operable but have a HER2 disease or TNBC and more than clinical stage T2, that is more than 5 centimeter, or node positive, and select high risk patients with clinically T1C or node negative HER2 positive disease and triple negative breast cancer. Similarly, large primary tumor relative to breast size in patients who desire breast conservation, and with node positive disease likely to become node negative with preoperative systemic therapy. Next. And then sorry, what's the need of response adapted adjuvant therapy in HER2 positive breast cancer? Next. So as we have discussed, the patient who did not achieve PAT CR, they have a poorer outcome. So HER2 positive breast cancer patient with residual disease have poor outcome. If we see the association of EFS and OS, if we see the first curve, the 5-year EFS with PAT CR 86%, with residual disease it's 63%. In HER2 positive disease. Similarly, the overall survival with PAT CR 5-year OS 95% and without PAT CR 76%. So there's a need for escalation of adjuvant therapy for residual disease patients for improving the overall clinical outcomes. Next. So if we look at building on trastuzumab, additional anti-HER2 therapy which have been approved in the adjuvant setting. First is the TDM1. It was approved in 2019 as adjuvant therapy for patients with HER2 positive early breast cancer and residual invasive cancer after invasive disease after neoadjuvant taxane and trastuzumab based treatment. Trastuzumab pertuzumab combination approved. It is approved in combination with chemotherapy as a neoadjuvant treatment, and for adjuvant treatment of patients with HER2 positive early breast cancer at high risk of recurrence, especially for patients who are hormone receptor negative and node positive. Then we have neratinib. It was approved in 2017 for extended adjuvant treatment for patients with HER2 overexpressed amplified ABC following adjuvant trastuzumab based therapy for up to 1 year. Next. Now, coming to the access of these three therapies, if you see neratinib, there's high cost, currently not available in India. There's no generic, and the toxicity also with diarrhea is pretty high. Pertuzumab, very high cost, biosimilar, although the trial is complete, still not yet available commercially. TDM1, again, it is available as a biosimilar too. So in India, most of the high-risk patients still get trastuzumab only as an adjuvant, but with the biosimilar TDM1 coming and the cost being affordable, so more and more patients are now getting access to TDM1. Next slide. Now coming to the landmark TDM1 study in early breast cancer, the Catherine study, which included patients with HER2 positive disease who were put on neoadjuvant therapy consisting of minimum 6 cycles of chemotherapy and 9 weeks of trastuzumab, and the patient were allowed to have pertuzumab too, and the patient who had residual invasive tumor in breast on axillary nodes post chemotherapy And post-surgery, they were randomized within 12 weeks of surgery into 1:1 to TDM1, 3.6 milligram per kg 3 weekly up to 14 cycles, and trastuzumab, 6 milligram per kg IV 3 weekly into 14 cycles. The primary endpoint was invasive disease-free survival, and the secondary were DFS, OS, DRFI, safety, and quality of life. Stratification was with clinical stage, hormone receptor status, preoperative HER2 therapy, pathological nodal status, and preoperative therapy. Next. So the primary analysis published in 2019, landmark analysis at baseline, there was a significantly prolonged DFS, and there was 11% DFS benefit at 3 years, 88% versus 77% with TDM1 compared to trastuzumab alone. OS at that time was not mature. We'll be seeing later on, and the hazard ratio for IDFS was 0.50. So there was a 50% reduction in the risk of progression or death due to cancer when patient who received TDM1 compared to trastuzumab alone. Next slide. So this is in December 2023, the long-term follow-up and updated OS analysis was published. Next. So again, it was a landmark analysis, 7-year IDFS 80.8% versus 67.1. So the difference is 13.7. So it has actually increased from 11%. So the absolute IDFS benefit of 13.7% at 7 years, it shows a big improvement over the standard of care. The hazard ratio 0.54, favoring TDM1 versus trastuzumab in patient who have residual tumor after neoadjuvant therapy. Next. Now coming to the overall survival benefit, again, the initial OS analysis did not show any benefit, but the updated 7-year OS, again showing a 4.7% absolute OS benefit at 7 years, 89.1% versus 84.4%, hazard ratio 0.66. So TDM1 is the first therapy to show significant overall survival improvement in this setting. So this was presented at SABCS 2023, again a landmark trial, again a landmark analysis at 7 years. Next. So again, the final EDFS by subgroup benefit was present across all the subgroup who were HER2 positive. Next. Again, benefits seen similarly across all subgroups. So how are these results important in HER2 positive breast cancers? So Catherine has introduced a new decision point in HER2 positive early breast cancer post neoadjuvant therapy. The treatment should be optimized based on the response to neoadjuvant therapy. So for newly diagnosed high-risk HER2 positive breast cancer or early stage breast cancer, trastuzumab plus pertuzumab based neoadjuvant therapy for 4 to 6 cycles followed by surgery, assessment of residual disease. So if there is pathological CR, then you can continue either the dual or single trastuzumab for up to 18 cycles. Then if the patient does not achieve path CR, then there is an opportunity to tailor treatment to TDM1 in adjuvant setting, which has led to improved IDFS as well as overall survival. Next slide. Now coming to another affinity trial, it was the international randomized double-blind placebo-controlled phase 3 trial in patient who had undergone surgery, patient with HER2 positive EBC, no prior invasive breast cancer or anti-cancer treatment or RT, with baseline ejection fraction more than 55%. It randomized to chemotherapy plus trastuzumab with pertuzumab or chemotherapy plus trastuzumab plus placebo for up to 1 year. Primary endpoint IDFS, secondary endpoint OS, DFS, recurrence-free survival, safety, cardiac safety, and health-related quality of life. Next. So the updated results of the affinity at 4 and 6 year median follow-up. If we see the benefit of adding pertuzumab in the adjuvant setting, it is mainly in the node positive subgroup. The benefit is in excess of 4%, 4.5 at 6 year IDFS benefit, and at 8 year 4.9% benefit. Next slide. So this is the latest proposed strategy for managing patient with stage 1 to 3 HER2 positive EBC. If the patient is T2 or more or node positive, neoadjuvant chemotherapy plus dual HER2 blockade, trastuzumab plus pertuzumab should be given. And if the patient and then the patient should be taken off of surgery. If there is pathological CR, continue trastuzumab for 1 year. You can add pertuzumab if there is node positivity. Then if non-path CR, again TDM1 for 14 cycles. And if the patient has gone upfront surgery and we have a T1N0 disease, so you can use a Tolani regimen, that is 12 weekly Pacli plus 1 year of trastuzumab. Or if there is any with node positive, then you give adjuvant chemotherapy plus dual anti-HER2 therapy for up to 1 year. So you can use neratinib for extended duration post 1 year completion of her trastuzumab, but it is not yet available in India. Next slide. So to summarize, for patient with HER2 positive breast cancer, the availability of HER2 targeted agents have markedly and rapidly improved overall outcomes. There is a need to offer neoadjuvant treatment for most of the eligible HER2 positive patients to adopt a response based treatment modification. For adjuvant therapy, Catherine, the TDM1 has adjuvant therapy for patient with residual invasive disease after neoadjuvant taxane and trastuzumab based treatment. More confidence with newer data with longer follow up, overall survival benefit is there. For affinity, dual HER2 therapy with trastuzumab and pertuzumab either continued for a total of 1 year after neoadjuvant chemotherapy or with adjuvant chemotherapy for a total of 1 year, especially for node positive patients. Few ongoing trials may open new horizons in future. Thank you. So I think we will move on to the next session, which is sponsored by Roche. And for that, I would like to invite Dr. Gurvinder Singh, who is a consultant medical oncology at CCA Ludhiana, and he'll be talking about paradigm shift in the management of HER2 positive early breast cancer. Over to you, Dr. Gurvinder, and a very welcome.
So thank you, Dr. Priyanshu, and thank you for the invitation. So I'll share the screen. So the topic is impact of dual HER2 blockade on early HER2 breast cancer, and it's sponsored by Roche. So as it is already being known that achieving a pathological CR is very important in any breast cancer, as pathological CR correlate well with the overall survival. Adding pertuzumab along with trastuzumab, and it has increased the pathological complete response around, it has shown in studies that it goes from 25 to 40%, and in some studies 60-70 also. That correlates with the good overall survival. And patients achieving a neoadjuvant dual HER2 blockade have shown good EFS benefit as compared to single agent trastuzumab. Event-free survival in early HER2 breast cancer, it is a pooled analysis after HER2 the targeted therapies. So regardless of pathological CR status, EFS reduction was much better with the dual HER2 blockade as compared to single HER2 blockade. So these are the studies that have shown that a dual HER2 blockade had a good cardiac safety. As we can see in both the cohort, either in dose dense AC followed by docetaxel, pertuzumab or trastuzumab, or CEF followed by docetaxel with pertuzumab, trastuzumab. So the cardiac safety was equal. It was not on the higher side, and EFS rates were better with this dual HER2 blockade. This is the pooled analysis from a recent Peony 3 trial that has shown a neoadjuvant dual HER2 blockade had a EFS and OS benefit over single agent trastuzumab. So moving to the current status of dual HER2 blockade, these are the NCCN guidelines in which HER2 positive disease TCHP regime is the preferred in HER2 positive for adjuvant, and also pertuzumab is now standard of care in neoadjuvant in a patient with a disease of T1C or above. These are the NCCN guidelines showing pertuzumab with trastuzumab category 1 indication in HER2 positive disease in adjuvant therapy. In the metastatic setting in a HER2 positive breast cancer, pertuzumab with the docetaxel and trastuzumab is the category 1 indication, and it is the preferred regime. These are the guidelines from ISMO, how we manage a HER2 positive early breast cancer. So if it is clinically T2 or above, or a node positive, or even if T1C and above, we start with the 6 to 8 cycles of chemotherapy with dual HER2 blockade, and then the patient proceed for surgery. If there is a residual invasive disease, then adjuvant trastuzumab emtansine is preferred. And if there is a pathological CR, it depends. We can go ahead with the dual HER2 blockade or a single HER2 blockade depending on the nodal status at baseline. So shifting IV therapy to subcutaneous therapy is a major impact on the patient and their family. As we know that for IV we need intravenous access, and HER2 therapy is like a prolonged treatment even in neoadjuvant or adjuvant setting. Then we need a PICC line or a port that has financial issues, and there is a risk of infections or a clot or thrombus. These are the burden that are faced by patients during IV treatment: financial issues, then emotional support, and every time there is a concern regarding IV pricking or a cannula. And the length of treatment is prolonged when we do a IV infusion with the trastuzumab and pertuzumab, because patient has to travel, then the blood test, waiting time, then a cannula insertion, then infusion time of pertuzumab, trastuzumab, and a chemotherapy will add on. It can take up to 8 to 10 hours also of the patient. So these logistic challenges, they are overcome now by subcutaneous formulations, as these logistics leads to negative impact on the patient, and it can lead to depression and anxiety, and depression is associated negatively with the survival of patients. These are the challenges which are faced while IV infusion: long infusion hours, and which will lead to time consumption, and intravenous access issue, placement of port or PICC line. So Phesgo is a dual HER2 blockade that combine both the trastuzumab and pertuzumab and is ready to use subcutaneous injection. And it is injected easily in 5 to 8 minute time. So these are the studies, Federici and Francis' study, which have shown the equivalent outcomes of IV and subcutaneous formulations. And the willingness was shown by Francis CA study. The patients were very easily willing to go from IV formulation to subcutaneous formulations. These two studies have shown the equivalence of subcutaneous and IV formulations, and the acceptance of subcutaneous formulation was much higher for subcutaneous as compared to intravenous. If we talk about the side effect profile, it was like diarrhea was less in the subcutaneous formulation, and injection site reaction were higher in the subcutaneous. Rest were almost similar, and I'll rather say it was less in Phesgo. Willingness from shifting from intravenous to subcutaneous was higher in subcutaneous, was higher in this IV form, subcutaneous form, and healthcare professionals, they are also more comfortable for using subcutaneous formulation as it reduces the timing. This is the study showing the much acceptance of subcutaneous formulation as compared to intravenous. So if we talk about the cost effectiveness of HER2 targeted therapy in neoadjuvant setting, so this fixed dose combination Phesgo as a much more cost effective as compared to another formulations. So conclusions of this is like neoadjuvant treatment with a dual HER2 blockade in this scenario in early breast cancer is the category 1 treatment, followed by continuation of either HER2 dual blockade or transition to TDM1 depending on the pathological response. And this fixed drug combination, it has more acceptance and is much more economically feasible as compared to IV formulation. So this subcutaneous formulation, patient is free from lines and patient has a much acceptance. Thank you all, and thank you for patience listening.
Thank you, Dr. Gurvinder. So, in the interest of time, we'll be moving to our last session, which is sponsored by Sun Pharma. And for that, I would like to invite Dr. Kanika Sharma, who is Associate Consultant Medical Oncology at Max Hospital, Mohali. And she'll be speaking about PARP inhibitors in CA breast, progress made so far, and future direction. So over to you, Dr. Kanika.
Hi, Priyanshu.
Hi, how are you?
I'm good. Since this is the last presentation, I will take less time. Just a minute. Yeah. So after discussing about the HER2 positive subgroups and the difference, so we'll be talking about the PARP inhibitors in carcinoma breast in the definitive setting, the metastatic setting, and what are the future trials that are coming in the BRCA positive patients. So as we all know that the biomarker testing, which we all routinely do in our patients, so the routine is the ERPR status and the HER2 status, along with the gene expression assays for the patients who are hormone positive early stage to guide the adjuvant chemotherapy, and the BRCA testing, especially for patients who are triple negative male breast cancer, who have a family or personal history criteria meeting this, and when we are considering. In my practice, I usually do BRCA testing for all the patients, and I have seen that without even meeting the criteria, the BRCA tests do come positive in some patients. So as we were discussing for the NCCN guidelines on testing, so again, the patients of any age who have triple negative histology or a multiple primary breast cancer, lobular breast cancer, or a personal family history of a diffuse gastric cancer, Ashkenazi Jewish ancestry, or if more than one close relative is there with a breast cancer diagnosed at a relatively younger age, ovarian or pancreatic cancer, or a prostate cancer. So in these subgroups, we do consider doing for a genetic testing, even not just BRCA, we do a extended hereditary panel also to see whether any other genes are involved or not. So when we talk about the incidence of BRCA mutation, the most commonly it is seen in the triple negative subgroup, but even the hormone positive subgroup, there is around 10% of the patients who comes out to be BRCA mutation positive. And we also do it prior in the definitive setting also, because in our practice, we are routinely following for the prophylactic surgeries also. So we counsel them patient for TH, BSO also, and the contralateral mastectomy also to reduce the risk. So it's better to do it at baseline. So by the time we are complete with the neoadjuvant therapy and planning for surgery, we can take the decision for the surgeries also. So coming to the trials that address the olaparib in the BRCA mutated germline positive patients. So first is the Olympia trial that have come up in the high risk primary breast cancer. So this in this trial they have included men and women who were BRCA germline positive high risk patients. So they have taken into two subgroups, that is the triple negative and the hormone positive HER2 negative subgroup. So patients who have received neoadjuvant and have not achieved a complete pathological response, so all those patients were taken in both the subgroup. When we are doing upfront surgery, so in triple negative, any node positive or more than equal to T2, that is more than 2 centimeter disease, they have considered for adjuvant treatment. In hormone positive, they have taken more than equal to 4 lymph node positive as the inclusion criteria. So they have randomized into 1:1 ratio to olaparib, 300 mg BD for 1 year, or placebo. So when we see the baseline characteristics, so it was equally distributed between the two arms. Most of the patients, they have BRCA1 mutation, that is in the 70% of the patients, and remaining of the patients, they have a BRCA2 mutation. When we talk about the prior treatment, so around half of the patients they have received in the adjuvant setting chemotherapy, and half of the patients have received neoadjuvant. Even 26% of the patients they have received platinum based. So like I'm also practicing for the patients who are triple negative, we are using a platinum based chemotherapy in the neoadjuvant settings. So when we talk about the invasive disease-free survival in the Olympia trial, so as you can see, there is a significant difference and there is a separation of the graph that we can see. So when we talk about the 4-year invasive disease-free survival, it is 82.7% versus 75.4%. That is significantly, with a hazard ratio of 0.63 going in the favor of olaparib. So when we see this forest plot, all the subgroups, they benefited from olaparib, addition of the olaparib. That was more pronounced in the triple negative breast cancer, but it was also seen in the hormone positive subgroup. Though the prognosis is overall good in the hormone positive subset, but still the addition of olaparib, they adds to the benefit. When we talk about the overall survival, so the overall survival with olaparib, it crossed the pre-specified boundary of significance. And as we can see, there was 3.8% difference at the 3-year overall survival rate, and it was consistent. So when we even see after 1 year, 4 year also, it was 3.4%. So again, in the forest plot for the subgroup analysis of overall survival also, the benefit was seen in all the subgroups, irrespective of whether the patient have received chemotherapy in the adjuvant or neoadjuvant setting, or whether the molecular profile of the patients. So coming to the safety profile, as we all know that the main side effect is the hematological toxicity, the nausea, vomiting, the fatigue that we see, which actually, limits us from using the full dose. But I think as compared to the ovary, the patients in breast cancer, they are relatively more tolerable to the full dose of olaparib. And hardly I've used in 4 patients, and 3 of the patients, they are still receiving full dose without any considerable toxicity. When we talk about the rare side effects like MDS, AML, I'm yet to find some patients who have these, but otherwise it's a well-tolerated drug. So coming to the flowchart, I think there is a lot of still missing points in this flowchart. So when we talk about the very early disease, that is T1, T2 node negative, so that is the same protocol that we follow for all the patients. If the patient have not achieved a complete response, pathological response, we give capecitabine. Or if the patient was taken up for Keynote 522 trial, then we complete the pembrolizumab therapy. So we are not using olaparib, and at least I am strictly restricted to the Olympia inclusion criteria only, that the patients who have node positive or who have higher T stage. So in that subgroup, if the patient have received complete response, pathological response, then the patient is continued on either pembrolizumab, if I've started them on Keynote 522 trial based on that, otherwise the capecitabine. And in the hormone positive subgroup, I'm more inclined towards using the hormonal therapy based on the addition of CDK4/6, depending on the risk criteria. So, but if the patient have not received those, then olaparib can be added. The main issue that is coming up is if the patient have not received the complete response, so whether to add capecitabine along with olaparib if we are not following pembrolizumab arm, because we know that it is safe to combine olaparib with IO. But capecitabine and olaparib, there is no such data. And the bigger issue is with the hormone positive subset, in which we don't actually, there is no data because the hematological toxicity will be higher. That is the addition of abema or ribociclib along with olaparib in the patients who have a higher number of node positive disease. So when I was going through a review article, so they have mentioned because the olaparib inclusion criteria is up to 2 years also. So you can give olaparib for initial 1 year, and after that you can add CDK4/6 if there is a high nodal burden. So we have patients who come with 6 to 8 to 10 node positive, and we want to give everything because they are young patients and the prognosis is actually bad if the disease recurs. So in those patients, initially we can go ahead with olaparib for 1 year and then add CDK in the later lines. So again, as we have discussed, that the patients who are eligible for adjuvant olaparib in the hormone positive who have higher number of confirmed positive lymph nodes, and in the triple negative, any node positive diseases are eligible for adjuvant olaparib. Sequencing, again, chemotherapy, nowadays everybody is following the neoadjuvant protocol to assess the response rates. So that radiation is completed before starting olaparib. Endocrine therapy can be given concurrently with the olaparib, and there is no added toxicity, and even the bisphosphonates can be given. So now coming to the locally advanced and the metastatic settings of HER2 negative breast cancer. So that is the Olympia trial that have come for the olaparib versus chemotherapy arm. So patients who are HER2 negative, who have a deleterious germline BRCA mutation positive, and who have received prior anthracycline and taxanes. So these patients were randomized to olaparib versus chemotherapy. So the baseline characteristics were comparable. Again, the BRCA1, BRCA2 mutations, they were equal in both the arms, and around half of the patients, they were triple negative and half were hormone positive in these lines. So when we talk about the progression-free survival, as we can see, there is a 2.8% benefit with olaparib as compared to the chemotherapy. I think that the responses are also because the patient have received chemotherapy 2 lines prior. So the bone marrow reserve is already less and the chances of tolerating olaparib becomes less in this setting. So again, when we talk about the overall survival, so there was a meaningful OS benefit who have not received chemotherapy for the metastatic setting. I think for the same reason, because they were better able to tolerate olaparib when we have given in the first line setting. And as we have given more line of chemotherapy, the bone marrow reserve may be diminished and they have a more resistant disease that is, not respond to olaparib. So then we come to the other PARP inhibitors. So there are trials for the talazoparib, that is the EMBRECA trial, which have compared talazoparib with chemotherapy in the BRCA positive or HER2 negative breast cancer. And again, the inclusion criteria was same, but they have taken less than equal to 3 previous line of chemotherapy for the advanced disease. And it was continued until the progressive disease or unacceptable adverse effects. So the primary endpoint was the progression-free survival and the secondary were overall response rate and the overall survival. So when we see this data, so when we talk about the PFS data, there is a 3-month benefit when we have given the PARP inhibitor, that is talazoparib, as compared to the standard chemotherapy arm. And when we talk about the percentage, that is the 1-year PFS, that is 37% versus 20%. So there was no OS advantage for talazoparib, and it was consistent across all pre-specified subgroups. So when we talk about the tolerance profile of olaparib and talazoparib, since we don't have a very practical experience of using talazoparib as it's not available, but comparing the 2 trials at the Olympiad and BRCA, so the tolerance and the side effect profile, it's worse with talazoparib, almost doubling of adverse effect as compared to olaparib. So when we see the anemia, neutropenia, thrombocytopenia risk, it is almost 16 versus 40%, 9 versus 20%. So there is a significant difference between the 2 drugs. Although the MDS AML incidence was not there between the 2 arms, but the rest was more with talazoparib. Then coming to the BROCAD 3 study design that have shown veliparib along with the paclitaxel versus placebo versus paclitaxel. So they have taken into 2:1 ratio randomization. Again, they have taken advanced breast cancer with a germline positivity less than equal to 2 prior lines of cytotoxic chemotherapy. And the patients who have progressed within 12 months of completing, not progressing within the 12 months of completing the chemotherapy. So when we see the PFS data between the 2 arms, as we can see, there is a slight difference, that is a 2 months difference with the addition of veliparib as compared to placebo along with chemotherapy. And it significantly improved with it, but numerically, there is not much difference that we can see between the 2 arms. Now coming to the triple negative breast cancer, now there are various studies that have been coming up with the addition of PARP inhibitor with the IO. So as we were discussing in the adjuvant setting also, so there is not much problem when we are using Keynote 522 trial, that there is the combination of pembro with olaparib. So the same combination they are trying in the metastatic setting also, that the patients with the untreated, locally recurrent and inoperable or metastatic TNBC, or if there is a recurrence within 6 months after the completion with curative intent and who have a confirmed PD-L1 status. So they have randomized patients, initially platinum-based chemotherapy plus pembrolizumab. After that, for maintenance, they have given olaparib plus pembrolizumab versus platinum-based chemotherapy versus pembrolizumab. So this I'm not sure who all are practicing, because they have used gem-carbo in the induction setting. And in the other maintenance arm, they have continued gem-carbo till there is a toxicity or progression. So this further causes thrombocytopenia and continuing carboplatin. So they have continued in this arm. So the again baseline characteristics were equal when we talk about, so around 78% of the patients, they have a CPS score of more than 1. The remaining they are PD-L1 negative, and the BRCA mutation was positive in around 21 to 22% of the patients. They have also taken the HRD score, so that was positive in the around 60% of the patients. So when we talk about the median PFS in months at 6 months and 12 months, so there is a slight difference when we talk about the 12 month, it is 33.3% versus 30 months. So a longer follow-up is needed to definitely say whether the addition is okay. And I'm still a little apprehensive about the continuing of chemotherapy arm with the pembrolizumab. Because in our practice, we actually continue with the immunotherapy alone when there is a response, and just stop after maximum 8 cycles of chemotherapy. So when we talk about the secondary endpoints also, when we talk about the specific subgroups and the patients who have a CPS score of more than equal to 10, so there is a difference. So it is significantly better. That is the 40.7% versus 30.9 months. And in the patients who are, germline mutated, BRCA mutated, so in that it is 50.2% versus 45.1%. So the difference in the specific subgroup is higher. So we can consider this combination in the patients who have a high CPS score or who are BRCA mutated. So combination is well tolerated. So when we talk about the safety, so I think the chemotherapy itself is toxic when given over a prolonged period of time. So as we can see, the grade 3-5 toxicity, it was more in the chemotherapy arm as compared to the olaparib plus IO arms. Again, there are various other studies, that is the DORA, in which they are trying with the combination of durvalumab. Then there is Mediola that is coming up, again Durva plus olaparib plus durvalumab. So a different combination of trials. So we need, another 1 to 2 years to get a definitive data on these trials also. But it is interesting to see that so many combinations are coming up, because in the TNBC, it's a slightly aggressive tumors, and we actually run out of options after 2 to 3 lines of therapy. So thank you so much for patiently listening to it.
Thank you, Dr. Kanika. I think so you've answered most of our questions regarding, I think so there is one question from Dr. Rajat. TNBC metastatic germline BRCA, de novo metastatic PS1. Would you offer olaparib in first line, or should you be doing PD-L1 in this setting?
So not PD-L1 as PD-L1 I will do, but if I have to add, I will prefer to add it in the maintenance setting instead of adding it frontline. So I would initially like to give chemotherapy, control the disease, and then add PARP inhibitor in the maintenance setting.
I think so we don't have the right answer now to what to do if we have a probably hormone receptor positive N2 disease who is BRCA positive and in the adjuvant setting, probably 1 year of OLA and then 1 year of Abema. Similarly, what we have to do we don't have the right answers even with the TNBCs in non-BAT
At the
CR
time
patients.
these trials were designed actually, so they were parallel design. So no new trial can be designed based on the combination actually. So that is.
So I think for a long, and I think so with the availability of generic olaparib, so we'll be using much more of these combinations, probably sequencing also. So maybe we might have some anecdotal experiences with these drugs in future. So thank you everyone.
If we have time. Hello.
Yeah.
So definitely, because olaparib generic has been available now, so we would not be looking at the data and looking more at the personalized therapy for the patients. It may change depending upon how the patient is responding. If the patient has responded beautifully, continuing immunotherapy and preserving olaparib maybe for the second line can be a thought. But definitely, as the trials evolve and as we grow and use these drugs more, we'll tend to understand what is the best possible way to use them. I feel using them judiciously may be a better way to go ahead.
but we don't do it in the other setting. It's like lung, we don't preserve the best regimen for the later lines of therapy. So I think if the patient is germline mutated, you want to add olaparib in the initial lines rather to save it for the later lines when the patient progresses.
So then I think using immunotherapy may not be of any benefit. Use olaparib instead of immunotherapy.
Yeah, because we have a target and it is efficacious. So I would like to use a PARP inhibitor initially rather adding immunotherapy later on, actually.
Right.
So I think so in neoadjuvant, the main impact of immunotherapy is to increase the PATH CR. And if you achieve a PATH CR, then you don't need actually adjuvant olaparib. So in neoadjuvant, we have to give our best if the patient reaches us first rather than the surgeon. So I think maybe AC and Paclitaxel plus Pembro, and try to achieve as much as PATH CR, at least in TNBC.
Right.
So we like to conclude today, and I'd like to thank all my academic partners, Roche, AstraZeneca, Natco, Zydus, Dr. Reddy's, Intas, Merck, Cipla, Fresenius Kabi, Novartis, Pfizer, Lalpath, and Reliance. And thank you to all the participants and the patient hearing which we have had. And I'd like to thank the organizers and the tech support team. And a very good evening to everybody. And that's all which we have for today.
Yeah, thank you.